Sir, shall I share my screen? Wait, Ankur sir.
Yeah, you can, ma'am, but we are not still live. You can.
Okay.
You are live, sir.
Very good evening, everyone. I am I'm delighted I'm delighted that we are having this PG refresher course, which is ophthalmology crash course, and I am happy that we have a great set of speakers today, which are going to talk to you about retina and its pathology, and they are going to share you the deep insights that you should know before your examination, and they will also help you to understand the subject better. So to begin with, we have our first speaker is Dr. Anugraha. She's a director of vitreoretinal services at Mahatma Eye Hospital from Trichy. Over to you, ma'am.
Thank you, Ankur sir, for the introduction. I would like to thank our professor and Dr. Madhuvanti for this opportunity. So I'll be talking on diabetic retinopathy, its etiopathophysiciology and classification. So first, going to diabetic retinopathy, you should know how a normal fundus looks like. So basically on the left side, you see here, this is how a normal healthy disc looks like and the macula and the background retina. In diabetic retinopathy, there are two types. One is non-proliferative, other one is a proliferative. The various findings that you're seeing here, like dot and blot hemorrhages, microaneurysms, hard X-rays, corneal spots, new vessels. So I'll be discussing about each one in detail in next slides. So coming to etiopathophysiciology, the first most common thing is the systemic. That is, more the duration of diabetes, the more the chance of patient to develop diabetic retinopathy is more. So more than 10 years the patient has diabetes, it is 50%. If it's more than 30 years, it is 90%. And in type 2 diabetes, they have 5% chance. And the other risk factors are pregnancy, hypertension, nephropathy, dyslipidemia, anemia, poor glycemic control, and smoking. Now, diabetic retinopathy per se is a microangiopathy, and it occurs at the level of retinal, precapillary arterioles, capillaries, and venules. Two types of changes occurs. One is the capillary change, other one is the hematological change. So basically, the capillaries, what happens? There is degeneration and loss of pericytes, proliferation of endothelial cells, thickening of basement membrane, and occlusion. And the hematological change is what occurs. The RBCs, they undergo rouleau formation because of which there is defective oxygen transport. There is increased plasma viscosity because of aggregation of platelets and increased stickiness, and all these things leads to occlusion. So now I'm going to tell you at the level of capillaries, venules, what happens. At the level of capillaries, occlusion, dilatation, microaneurysm, and abnormal permeability. At arterioles, it is narrowing of terminal arterioles, occlusion, sheathing. And veins, you have the tortuosity, looping, beading, and sausage-like segmentation. So summing up all these together is your etiopathophysiciology. So basically, at the endothelium, you have thickening of the basement membrane, and there is changes in the RBCs, thickness of the platelets, everything. All these things together, it leads to microvascular occlusion, and that leads to retinal ischemia. You can see here the figure here in the endothelium. You can see here the basement membrane thickening. There is loss of the pericytes, RBC changes occurs. There is rouleau formation, platelet thickness. All these things together leads to occlusion and leakage. So in vascular changes, because of retinal ischemia, it leads to all these findings like your capillary leakage, microaneurysms, hemorrhages, retinal edema, hard X-rays, your IRMA, that is arteriovenous shunts, and your neovascularization. So whenever there's hyperglycemia, microangiopathy occurs, there is increased vascular permeation. You can see here it all leaks, the retinal capillary leaks occurs. So now coming into each and every findings, what is the pathology behind that? So what are microaneurysms? They are nothing but saccular outpouching of the capillary walls. You can see here. So the microaneurysm will be red, round structure, and it is 30 to 120 microns. It occurs at the level of inner nuclear layer. So you can see here this dot and blot hemorrhages here. They occur because of the rupture of the leakage of the deep retinal capillaries. So it is most commonly seen in the middle layers of the retina, most commonly the inner nuclear and your outer plexiform layer. So flame ship hemorrhage, they occur from the you can see here all these streaks, like these are all the flame ship hemorrhages. It occurs from the large superficial precapillary arterioles and occurs in the nerve fiber layer. And corneal spots, you can see here this white fluffy structure you're seeing here, all these are corneal spots. These are nothing but ischemic infarction of the nerve fiber layer, and it's composed of accumulation of neuronal debris within the nerve fiber layer. In FF, you can see block fluorescence like this. And next is the hard X-ray, the nice glistening yellow, well-defined structure. It occurs at the junction of a chronic localized retinal edema and the junction of a normal retina. So it's composed of lipoprotein and lipid-filled macrophages, and it's present in the outer plexiform layer. So from PG point of view, they'll be asking you like, what is microaneurysm, how it occurs, dot and dot hemorrhage, from which which capillaries or which layer it occurs, and what is all composed of all these hard X-rays, cartoon spots. Thus, this is a small animation video showing you the difference between non-proliferative and proliferative diabetic retinopathy. So the word itself means non-proliferation, basically there's no new blood vessels. And proliferation, you're going to have new blood vessels on the disc or new blood vessels elsewhere. In non-proliferative diabetic retinopathy, diabetes is mainly a posterior pole disease. So most of your findings are going to be confined to your posterior pole. You can see here the sacral outpouching or all your microaneurysms, dot and blot hemorrhages. And proliferative, your diabetic retinopathy, you're going to have all the new vessels on the disc and new vessels elsewhere. Coming to the ETDS, that is early treatment diabetic retinopathy study classification of diabetic retinopathy, is classified into two. One is a non-proliferative diabetic retinopathy, other one is a proliferative diabetic retinopathy. In non-proliferative, you have no diabetic retinopathy, mild non-proliferative, moderate non-proliferative diabetic retinopathy, severe non-proliferative, and very severe. In proliferative, it is mild to moderate proliferative diabetic retinopathy, high-risk proliferative diabetic retinopathy, and advanced eye disease. So so how do you screen the retina? How do you see? You can use your 90D lens and slit lamp, you can see. Divide the retina into 4 halves. Like how the clock has all the 12 clock hours, you start scanning one clock hour from posterior to anterior. So 1, 2, 3 clock hours, 4, 5, 6. Similarly, cover all the clock hours, scan each and every part. Ask the patient look down, look up, right side, left side, all 8 quadrants, screen the retina completely before coming to conclusion no diabetic retinopathy. Put the patient flat and see an indirect also. So this retina is absolutely normal. There is no changes in diabetic retinopathy. When the patient's having no diabetic retinopathy, always call the patient yearly once, and that should be fine. And in very mild, you will just have only microaneurysm and review the patients every 12 months or 9 months. You can see here just the microaneurysms only here. There's 2 things here. And in mild non-proliferative diabetic retinopathy, any or all of the findings, either microaneurysms, retinal hemorrhage, exudates, corneal spots, up to the level of moderate non-proliferative diabetic retinopathy. There is no IRMA or venous bleeding in this. Review these patients 9 months once, and depending on the systemic condition, you can see here. So basically, you split the retina into 4 halves. At least if in one quadrant you're seeing these findings, either you can see your corneal spots in this, so this is going to be mild. You can see just a dot hemorrhage here, corneal spot. This is also going to be a mild non-proliferative. And in moderate non-proliferative diabetic retinopathy, you at least in 3 quadrants the findings should be present. That is called as 1, 2, 3 quadrants. You can have severe retinal hemorrhages. Significant venous bleeding can be present in no more than 1 quadrant. Corneal spots are commonly present, and the follow-up period is going to be 4 to 6 months. The chances of moderate non-proliferative diabetic retinopathy to become PDR is 26%, and that becoming higher risk PDR is 8% within a year. So if you split the retina into 4 halves, you're seeing in this quadrant and this quadrant and this quadrant, you're seeing dot and blot hemorrhages. You can see dot and blot hemorrhages, venous bleeding is present here, and you can see your corneal spots, hard X-rays, all these are present 3 quadrants. So similarly, in this figure also, you can see a lot of corneal spots here and dot and blot hemorrhages. So split the retina into 4 halves. At least in 3 quadrants, you're seeing these findings, it is going to be a moderate. You're seeing in 1 quadrant, just 1 or 2 findings, it's going to be a mild. And coming to severe. In severe non-proliferative, the 4-2-1 rule, 1 or more of the following: 4 quadrants of severe hemorrhages and 2 quadrants of venous bleeding, or just 1 quadrant of IRMA. This comes under severe non-proliferative diabetic retinopathy, and review the patients 3 months once. PDR occurs in 50% and high-risk chances are 15% within a year. So all 4 quadrants, you're seeing all the findings. Basically, you're seeing the dot and dot hemorrhages, microaneurysms here, hard X-rays, and flame-shaped hemorrhages, everything in all 4 quadrants. So this is severe non-proliferative diabetic retinopathy. There's one more figure here. You can see your venous bleeding is present. There is IRMA present here. So scan the retina and you'll be able to pick up all the findings. This is also severe in all 4 quadrants. You're seeing this. You're seeing hard X-rays here, dot and blot hemorrhage in all 4 quadrants. So this is severe. So keep it very simple. In mild in 1 quadrant, moderate is 3 quadrants, and severe is 4 quadrants. In very severe non-proliferative diabetic retinopathy, 2 or more criteria for severe NPDR. Review the patients 2 to 3 months once. The chance of this very severe to progress to PDR is 45% within a year. So in very severe, 2 or more the above criteria. So compared to the previous figures, you can see a lot of corneal spots are present in this, and 2 or more criteria of the above is present here. You can see the venous bleedings, hard X-rays, IRMA, and all this. Similarly, here also you can see the hard exudates here, a lot of dot and dot hemorrhage and extensive corneal spots. In these patients, you can do an FFA. So coming to proliferative diabetic retinopathy, in mild to moderate, new vessels on the disc or elsewhere is present, but it does not meet the high-risk criteria. So for these patients, for any pre-DR patients, you directly do a PRP laser and emphasize the need on the systemic control, and the follow-up period will be depending on that. You can see here, there's a small new vessel here, new vascularization elsewhere. Coming to high-risk proliferative diabetic retinopathy, there are three criteria for this. One is the new vessels on the disc more than 1/3 disc area, any NVD with vitreous hemorrhage, or new vessel elsewhere greater than half disc area with vitreous hemorrhage. These patients also PRP should be done immediately. You can see here almost the disc fully is having new vessels on the disc. Here, this is NVD on the disc with vitreous hemorrhage here. And here you can see NVD on the disc with vitreous hemorrhage. And here you can see a large NVE with subhilar hemorrhage. So all these things fits in the criteria of high-risk PDR. Coming to advanced diabetic eye disease, tractional retinal detachment, and a significant persistent vitreous hemorrhage and neovascular glaucoma, this all comes under your advanced PDR. You can see here, this is a traction membrane causing a tractional retinal detachment in the macula here. And this is a persistent subhilar hemorrhage for a long time with a tractional retinal detachment. So the small animation video showing you like how the new vessel bleeds into the vitreous cavity and causes the vitreous hemorrhage from the retina. So now coming to the classification of clinically significant macular edema, there are three types. One, if the thickening is present at or within the 500 micron center of fovea. Other one is hard exudates within the 500 microns of the center of macula with retinal thickening a part of it. And retinal thickening one disc area or larger, any part of which is within the center of the macula. The same thing what I told you here. So basically retinal edema is within the 500 microns. Here, hard exudates will be in the 500 microns and a part of retinal thickening will be within the 500 microns. Whereas the third one is a retinal edema, one disc area or very large, a part of which that edema alone will be present within your center. So this is the first type. Retinal edema is within the 500 microns. And this is hard exudate with a part of retinal edema and this the large one side disc area of edema, part of which is within the center. All these are types of clinically significant macular edema. Coming to clinico-angiographical classification diabetic maculopathy, you have focal exudative maculopathy where you have microaneurysms, hemorrhages, and this you have the cystinoid pattern. You can see here the focal leakages. And there's diffuse leakage here. This is diffuse exudative maculopathy. In ischemic maculopathy, there's FAZ enlargement. There is foveal avascular zone is enlarged, the capillary dropouts. In combined maculopathy, you have both the ischemic and exudative maculopathy. You can see here the FAZ is enlarged here. There's ischemic areas here and a lot of leakage here. This is a mixed maculopathy. So this picture, like I told you, see here, there's just one quadrant. You can see just hemorrhage here. This is mild. In moderate, you can see here in 3 quadrants, you can see the corneal spots here. And there's a few dot and blot hemorrhages. So basically 3 quadrants. And severe, all 4 quadrants, you're seeing the corneal spots, dot and blot hemorrhages, hard exudates. And this mild to moderate PDR, there's a small new vessel elsewhere here. And high-risk PDR, you can see here the extensive vitreous hemorrhage here. And this is advanced where your tractional retinal detachment and a long-standing vitreous hemorrhage. So yeah, thank you all for a wonderful hearing. Thank you.
Thank you, ma'am. Thank you for covering diabetic retinopathy in just 15 minutes. This is such a huge subject. You have books on it. But covering that much in 15 minutes is quite remarkable. And I think you have covered it all. And you have also covered the points that the postgraduate should know. You have covered the HRC. You have covered how to differentiate the NVDs and NVEs. What are the important investigations? Ma'am, if a patient comes to you for the postgraduate students, if the patient comes to you, diabetic retinopathy patients, so what are the 3 or 5 investigations that you would advise to these patients? What is a postgraduate should know that these are the investigations that they have to write? What are the basic investigations that they have to do? And follow-up we have already discussed. So these are just few things that if you can, sum it up.
Yes. So first, the postgraduate investigations coming diabetic retinopathy, basically systemic control is very important. So the PG should know to get the basic systemic evaluation in that the blood sugar profile has to be done. So FBS, PP, BS, HbA1c, and even lipid profile also comes into that. So this is the basic blood profile for the patient. That is first thing. Second thing, the patient's having macular edema, the PG can send for an OCT macula to see how the edema is and grade the severity of the edema. And in severe cases of non-diabetic retinopathy or very severe, if they have a doubt, it can be a PDR to know how much of capillary non-perfusion areas is there, fundus fluorescent angiography. So all these things has to be done.
Thank you, ma'am. Thanks a lot.
Thank you, sir.
Now we go to the next talk. The next talk for today is on non-proliferative diabetic retinopathy by Dr. Arpit. Yeah, there you go. Dr. Arpit, can we have your first slide, please? Yeah. So Dr. Arpit is joining us from Jaipur. He is an assistant professor and is a veterinary surgeon at Gitanjali Institute of Medical Sciences, Jaipur. Over to you, Dr. Arpit. You are not.
Now am I audible?
Yeah, you are.
Can you see my screen?
Yeah, you just have to share it. You've not shared it.
1 second.
Go full slide, na?
You just go to slideshow.
Shit.
Yeah.
Is it now?
Yeah,
Okay.
absolutely. Perfectly fine.
Right. So yeah, hello, this is Dr. Arpit, and thank you, Professor, for this wonderful opportunity and excellent lecture before me. So I'll be talking briefly about non-proliferative diabetic retinopathy and diabetic macular edema also, and why do we care about it? So before we begin, a few Viva anchors, and these things can be asked to you in your Viva. So among all the diabetics, what are the chances of having a diabetic retinopathy? That is around 35.4%, and among them 7.4% will have a diabetic macular edema, and around 11% will have a vision threatening diabetic retinopathy. And these data came from very important meta-AI study by Yao et al. Another important numbers that I think it has already been mentioned in the previous classes, if you have a severe NPDR, and what are the chances of it going into a PDR, that is 50% in 1 year. These numbers came from the ETDRS study. And if suppose you have a very severe NPDR which has already been defined, there are 45% chances of it becoming any PDR, at very high risk PDR, and 75% of any PDR. Another important number you are supposed to know is that in 10 years, diabetic macular edema incidence is pretty high in both type 1 and type 2 diabetics, that is around 20 to 25%. And these numbers came from the Wester study. Few Indian numbers are also important. That is, one study was from the Shankar Netralaya, which said there are proportionately more number of patients from the urban setup, that is around 18%. And very important numbers for you are the RAB India study, which said diabetics in all more than 50 years old, that is around 12%, and among them 17% have a diabetic retinopathy, any diabetic retinopathy, and among them 7% have a maculopathy. And these numbers you are supposed to know. So this is a classic, Wester study is a classic study which said what will happen in the patients with time if you are following that cohort. And they clearly said that it was much worse for the type 1 diabetics. That is almost 97% of them ended up with some kind of diabetic retinopathy in 25 years, almost 100%. Although it was fewer in type 2 diabetes, that was also very significant. So clearly there was a time factor involved, and the same time factor was there in the diabetic macular edema incidence also, where in 10 years almost 20% of the type 1 diabetics and 25% of the type 2 diabetics ended up with the macular edema. And diabetic macular edema can happen in any spectrum. It doesn't have to be a PDR or a severe NPDR or moderate or mild. It can happen in any diabetic retinopathy. Another important study that you are supposed to know is what will happen if we tend to follow them up maybe later than just 1 year follow-up. So what we found out was in 3 years, the incidence remains quite low, especially for the treatable ones. That is, PDR was only 0.7%, CSMA was only 0.6%. That was at the end of 5 years also. So easily you can follow up patients in 3 years. Another important study, that is DCCT. See, the one was the natural progression of the things, but the DCCT has proved the causality also. The happen if we control the sugar well. And for them, they had two pathways. One was the primary prevention, where patients don't have any microangiopathy. What will happen if we give a good diabetic control in them? And there was a secondary prevention cohort, which had some angiopathy. There was some microaneurysms or baseline diabetic retinopathy. And both of them, that was a randomized control trial compared to the common management. It reduced the DR incidence to 76% and progression to 54%. Although there was some worsening initially, but later on it caught up. Same study was followed up for many years later also, almost for 2 decades. And that was just to prove that if we control the diabetes well, initial years, there is a metabolic memory. So they tend to do well even later on. The same counterpart for type 2 diabetics from the DCCT was a UK PDS study, which showed that the diabetic retinopathy reduces by 21% if we are doing an intensive management. And the famous question of the 1% rule, for every 1% HbA1c, there is 25% lowering of the risk of microvascular complication. This is an exam question for you, and this will be asked. This came from UK PDS. And another thing it proved was what will happen if we control the blood pressure well. So it showed that the diabetic retinopathy progression reduces by 34% if you are controlling the BP by a target of 150 by 85. So the clinical takeaway here was tighter BP control and the sugar control both work well for these patients. But we say they are counterparts. They were not exactly the counterparts because the conventional method of both of them differed. Since DCCT was a type 1 diabetic study, we were giving injections. But in the type 2 diabetics, we are going only for the diet-led or the lifestyle modification. Then another important study was the ACCORD study. So what will happen if we are intensively targeting we already know that good target is good, but what will happen if we go even higher? So it was less than 7% for other studies, where we decided to go less than 6% also. So although the DR progression was decreasing, that was from 10% to 7.3%, there was increase in the mortality. That's why this trial was stopped early on. And similarly, there was a field study where we added fenofibrate and saw whether the treatable diabetic retinopathy decreases or not. So the number of intervention decreased for the DME and PDR when we added fenofibrate. That was the field study. So we know what the problem with the ACCORD study was. So what will happen if we go slightly higher, maybe not 6%, but less than 6.5%. So for these patients, the major problem was solved. That was lower cardiovascular risk and shorter durations. Was found is, and although the target of the was reached in both the eyes. So what we should learn from this thing is the targets of the sugar should be individualized, because if you are going for too much of hypoglycemia, they can trigger the cardiovascular risk, they can trigger arrhythmias, and very sick patients cannot tolerate this thing. And that is why the ADA also says this same thing only. So for the very poor patients or the complex heart problems or any sick patients, you don't go for a very risky targets. I think all these lesion photos are already been covered. What are the microaneurysms and dot blot hemorrhages? Where do they happen? So already these things have been covered. You don't have to go through it again. So yeah, talking about the diabetic macular edema. So there is never been a full one definition for saying, okay, this is the diabetic macular edema, this is how it should happen. Roughly, we know that there is a increased thickness of the macula, but one of the definition that we follow came from drcr.net protocol I, which said that center involving diabetic macular edema is the one which is most important, and that is more than 250 micron of the subfield thickness, plus there has to be decrease in the vision because of this. There are other ways of seeing diabetic macular edema also, that is diffuse retinal thickness or subretinal fluid or a cystoid macular edema, which are just the OCT placed classification, but even the authors have said that it doesn't make any difference to the vision. All these macular edemas are the same only as long as it is causing a vision problem. So morphology by OCT doesn't make a lot of difference, but you are supposed to know the names. Now another thing is severe NPDR. Why this 4-to-1 rule came? See, 4-to-1 rule didn't come from the ETDRS. ETDRS only gave the standard pictures. That was 2A, 6A, and 8A. And he said this is the mild, moderate, and severe NPDR. I think the definition has already been covered, but this is just the bedside simplification for it. And the 20 intraretinal, more than 20 intraretinal hemorrhage per quadrant also didn't come directly from the ETDRS. It came later on from the diabetic DRSS scale study. Now, the DRS was the study which started the laser photocoagulation era. I think PDR is the next lecture, but simply put, what they were looking for is whether the laser works for PDR or not, and what are the PDR which it works for, and that is where it defined the high risk PDR also. And in those patients, if we are giving a laser, the severe vision loss, which was defined by less than 5/200 vision and representing a 6 or more line loss or more than 30 letters or quadrupling of the angle, it was almost 50% reduced. The ETDRS filled up where the PDR had, DRS had left off. That what will happen whether it is when it is not a high risk PDR, what will happen if there is an NPDR only or a DME only. So for the DME, they went for the focal or the grid laser, and they said there is decrease in the moderate vision loss by 50%. It didn't say gain; it said decrease in the moderate vision loss by 50%. That, and what is the moderate vision loss? That is 15% or more letters or more than 3 lines. And it also said the scatter laser doesn't make any difference in the severe NPDR or PDR or moderate or mild NPDR. Severe NPDR, in few cases, you can still laser. And another thing they checked was aspirin 650 milligram per day didn't make any difference in the DR progression. But what was the macular edema that they were treating, and they found out that it is decreasing the moderate vision loss by 15%. They defined it as a clinically significant macular edema because they didn't have an OCT. So clinically, what you are seeing, one thing may be that you are seeing a hard exudate within 500 micron of the foveal center. But with that, there has to be an adjacent thickening of the retina, because without macular edema also hard exudates can exist. So this was one part of the definition. Other thing was whether there is a thickening within 500 micron of the center of the macula, or there is an entire area of more than 1 disc diameter, part of which is within 1 disc diameter of the center of the macula. All these things can lead to a vision loss. And this is what they were seeing clinically. This is before the OCT era. And ETDRS went for the focal and grid laser, and they said there has to be a visible burn. But eventually we started following modified ETDRS, which came from DRCR protocol A, where it's where you don't have to have a visible macular burns, and even the spot size can be reduced to almost 50 micron. So this was the laser era, but all these were saying that it reduces the vision loss. But what about the vision gain? So thinking behind it was, I think, although there is a separate lecture for the VEGF also, intravitreal injections also, but just briefly mentioning that since this is the main mechanism why the diabetic macular edema is happening. So we started trial with that also, starting from the read and restore trial, which was laser compared to the sham, and protocol I and rise and ride study. All these things established that ranibizumab can be used for your diabetic macular edema. But what about there are so many injections? What if we compare aflibercept with ranibizumab versus Avastin? So are they equal, or is there any difference? So aflibercept in protocol T showed some difference initially, that was at the end of 1 year for vision 20/50 or worse. There was a difference, but eventually within 2 years the difference also disappeared. Another important study that you're supposed to know, which are the diabetic macular edema you'll be treating. We already said which is the central involving diabetic macular edema, which is causing a vision loss. But if suppose patient has a 20/25 vision or better, can it be observed versus does it have to be given upfront injection? So from protocol, we know that for these patients, PRN management is also acceptable if the vision is better than or equal to 20/25. That is roughly around 6/9. And the protocol U also proved that we don't have to go very aggressive with the management. If we are already giving a ranibizumab, we don't have to give a DEX implant, because it is not causing any vision gain, but instead it is causing increase in the IOP. So that is about just the basic injection. But what about See, the major problem here was we have to give these injection monthly. It doesn't work more than that. So there are chemicals which can be given for the longer duration also. That is faricimab and brolucimab. And faricimab also has an extra mechanism, that is an anti-ang2. And it proved that even the extended dosing interval can be acceptable for faricimab. All these were compared to the aflibercept. And for steroids, we know from the MEAD and the FAME study for Ozurdex and fluocinolone respectively that for pseudophakic, maybe steroid is a good option, but for the phakic patients, there is increased cataract risk, and then there is an added risk of high IOP. So what are the steroid, what are the condition where you will be saying, okay, steroid is an option, whether when the patient is pseudophakic, whether it is a recalcitrant diabetic macular edema, whether there is a anti-VEGF poor response, or when there are too many exudates. In those cases, yes, you can go for the steroids, but you have to monitor IOP. That is what it's supposed to say in exams. Thank you.
Thank you, Dr. Arpit. Just one question that has come
Right.
online
Mhm.
is, I think we have already covered it, but then they were asking that if a patient of diabetic macular edema comes,
Mhm.
apart from the investigations that we should do for the metabolic status and the OCT, which anti-VEGF should we start the patient on treatment with? Which is the primary choice of anti-VEGF that we should treat this patient with?
Right. So in exam, if you are supposed to say, and if you have to back it with a study, you can always say, okay, the protocol T said aflibercept and ranibizumab and this bevacizumab are comparable in their results. Only the difference was initially there was a better result with the aflibercept for poorer vision patients, but that difference only lasted for 1 year. If they poke you more, okay, if the patient is not affording or patient doesn't want to come very frequently, those things, then you are supposed to say, okay, if they cannot come frequently, they then maybe go for newer molecules or omalizumab or faricimab, or if there is an affording problem, maybe go for, and for that you can give those studies maybe. I think it's part of the next presentation that you can say BOLT study is showed that you can give bevacizumab also.
Okay, thank you. We have been joined by our chairman of the session today, Dr. Shishir sir. I welcome you to the event. As we go on to our next talk, let me introduce our next speaker. And our next speaker is Dr. Alok Sen, who would be joining us from Chitrakoot. He's currently heading and is the director of Retina Services at Chitrakoot, and he's an well sought after teacher by most of his students as well as from other places. Over to you, sir. So your voice is not audible.
Am I audible now?
Yeah,
And
absolutely.
my screen is there.
Yes,
Yeah, slides are there. Okay, thank you so much, Dr. Ankur, for that kind introduction. And I'm grateful to Dr. Prafulla for giving me this opportunity. And I'll be speaking on management of PDR. And are my slides moving? Yeah. So, and I don't have any relevant financial disclosure for this talk. So as we all know, and we have been listening to beautiful talks before me, that the diabetic retina in diabetic patients, they go through certain stages. And initially, there is a state of compensated adaptive changes where we see no retinopathy, but the things can be picked up on maybe ERG. There is loss of autoregulation and other things. And then it moves on to where you have a state where there is a decompensation, which is known as adaptive decompensation, where you see all the features of diabetic retinopathy. And finally, you reach a state where you have aberrant repair, right? So here, what you see is proliferations. So this would be my focus of discussion in next 10 minutes or so. And if you see that the things take some time to occur, and that's the important that these are all time sensitive. And if you can identify these patients early, then you can prevent the aberrant repair state. So you can prevent diabetic patients going into proliferative diabetic retinopathy by just screening them time to time. So the pathophysiology has already been discussed. I just want to add one thing that PDR basically is not just retinal ischemia, but it's an abnormal vitreous as well, where there is vitreous chiasis because of the cross-linking of collagen by the advanced glycated end products, as well as there is early liquefaction. So not only the vitreous is more adherent to the retina at places of fibrovascular proliferation, but also the vitreous undergoes early liquefaction or syneresis. So, and that's the basis of traction to the new vessels, which then lead to bleeding and tractional retinal detachment. So it's not just the retina at fault, but the vitreous is also involved. Just to show you how the there would be fibrosis. And this is basically driven by collagen tissue growth factor. So there is a balance between VEGF and collagen tissue growth factor. And this we will come later on when we will discuss how anti-VEGFs can actually be harmful in certain PDR cases. Now, clinical features have already been described beautifully. I'll just want to re-emphasize on the fact that you should all SPGs know what is HRC PDR. I would not repeat it. And also what is advanced PDR. And the thing is, coming to what my topic is, management of PDR. The aim of management is to prevent severe visual loss, which was the aim of the DRS study as well. And this can be achieved by regression of the new vessels as quickly as possible. And there are several ways of doing it. It's a multi-pronged approach. You can't have one thing, can't do just one thing in these cases. The first is, of course, the importance of metabolic control, which any patients with diabetes and or diabetic retinopathy, this has to be emphasized. But one thing one has to remember that sometimes some of these patients, particularly who have had long-standing high HbA1c with advanced retinopathy, they can have worsening of retinopathy with intensive control. But that doesn't mean that you should not emphasize upon the importance of intensive or good control in these patients. Lasers, I think for more than 4 decades, lasers have been the standard of care for patients, for managing patients with for managing patients with PDR. And as was mentioned in the previous talk as well, that PRP reduces the incidence of severe visual loss in these eyes, especially HRC PDR, by almost 60% in 2 years' time. Now, and hence it was recommended by DRS that you should do a prompt or immediate laser if you see a patient with HRC PDR. However, when ETDRS looked into its own data, they suggested that not only, of course, the high-risk PDRs needed to be treated, but also if you have early PDR or severe PDR, but the other eye is lost because of PDR related complication, then it is wiser to laser them. Or if the compliance to follow up is questionable, again, it would be important to laser them. Patients with poor control, they are more likely to progress rapidly, and then hence you would like to laser them. Again, pregnant females who have even early PDR, you might think of lasering them. So see, these are certain conditions where you can think of lasering even before the patient reaches high-risk PDR, or even when the patient has very severe or severe NPDR. How does laser work? Basically, it destroys the peripheral ischemic retina, which is the source of VEGF at many a times. And this, so it decreases the oxygen demand because the photoreceptors are lost. So there is a decrease in VEGF level. At the same time, it also increases the diffusion of oxygen from the choroid into the inner retina, again, reducing the drive for VEGF. So these are the two ways by which the lasers work. And the technique for PRP may be asked in your exam, and this is from ETDRS protocol. Usually we do it on slit lamp. The duration is from 0.1. These are the settings that you should know. The duration of the laser is 0.1 to 0.2 mostly. The spot size as per ETDRS was 500 microns, but we all know that the spot size can vary with the type of lenses that you use. So you have to be aware that which of the lenses have what magnification, and accordingly you have to adjust the spot size. Most commonly what we use is the wide field lens, which has a magnification of 1.96. So the spot size is around 200 in most of our PRP cases. The intensity is moderate burn, and the spacing is about half to 1 burn width apart. And the area that we cover is from 500 microns nasal to the disc, just outside the superior and inferior arcade, and from about where the temporal arcades, and you then move on up to the equator. That is the area that you are burning, and you are anywhere giving about 1600 to 2000 burns, and that is usually distributed in 2 or 3 settings. So this is how you do a laser. How to monitor? You follow up the patients monthly, look for regression of new vascularization, and they will appear more, fibrotic. Look for reversal of vascular changes, like the dilated tortuous veins will become less dilated, and retreat if there is persistence of new vascularization that you see after 4 months of complete PRP. And that you do by doing fill-in laser. That is when you can do lasers in between 2 spots. You can go beyond the equator, or you can go within the arcade, one row within the arcade. So that is how you do a retreatment. Now there are several complications that that you see after laser. Ironically, laser can also sometimes induce PVD, and that can lead to vitreous hemorrhage. And hence, you have to counsel the patient that although you are doing laser to prevent vitreous hemorrhage, but lasers can induce PVD, and that can lead to vitreous hemorrhage as well. There can be worsening of diabetic macular edema. So particularly those in patients who have extrafoveal macular edema or have pre-existing macular edema, then you have to treat the macular edema first and then start treating the PDR part of it. There could be loss of peripheral field of vision, loss of night vision. This you have to explain, because some of them may be driving in light, or the field of vision may restrict their driving capability. Inadvertent foveal burns are not uncommon in novice hands, and you have to be very careful while you're doing PRP to mark your macula several times while you're doing PRP. Choroidal effusion or detachment have been reported, especially if you do the entire PRP in one setting, and in those who have pre-existing nephropathy. So in patients with pre-existing nephropathy, you have to be careful when you do PRP in one setting. Now, anti-VEGFs in PDR certainly have role. So we all know, although laser has been the standard of care, all anti-VEGFs provide an alternative to laser in PDR, and there are a couple of studies which have shown that not only anti-VEGFs are non-inferior to PRP, they cause less field loss, they have lesser risk of loss of vision because of diabetic macular edema, and there is lesser need for vitrectomy. Now, having said that, we must understand that the effect of anti-VEGF is only temporary. As you can see in this figure, we give anti-VEGF in this case of PDR. You can see in the middle picture, the new vessels have regressed to an extent, only to come back with greater vengeance. So you have to monitor these patients. If you are using anti-VEGF monotherapy, you have to monitor this patient probably till you have every vessel fibrotic. And also remember that in some of the cases where there is already a lot of fibrosis, not to inject anti-VEGF, because this can lead to, as we had discussed in the previous slides, that this can lead to an unabated effect of collagen tissue growth factor, leading to crunch phenomena, where you can have tractional detachment or even a combined mechanism RD. So the current role of anti-VEGFs in PDR would be as an adjunct to laser PRP, where anti-VEGFs provide you with immediate effect, while laser gives you more durability. PDR associated with diabetic macular edema certainly would like to treat the macular edema first with anti-VEGFs and then follow it up, top it up with PRP. anterior segment neovascularization, you need to treat with anti-VEGFs. They have shown to reduce the rubiosis and also reduce the IOP in some of the cases. Preoperatively, we are using routinely anti-VEGFs in patients who are posted for diabetic vitrectomy, and we'll come to that later. So management of advanced PDR, like we have been now talking since till now talking about PDR. Now, what about the complications of PDR, which include persistent vitreous hemorrhage, dense premacular vitreous hemorrhage, TRDs, or a combined mechanism RD? So these are the complications, sight-threatening complications, and these have to be dealt with pars-plana vitrectomy. The timing of surgery is also important, and it is said that in lasered PDR, if you have mild vitreous hemorrhage or not very dense vitreous hemorrhage in type 2 diabetes, you can still wait for spontaneous clearing of the vitreous hemorrhage. But in cases like type 1 diabetes, where there is no previous laser done, if the patient is one-eyed, if there is associated macular TRD, or a combined mechanism RD, or if there is presence of anterior segment neovascularization, you have to go in early as possible. So these are the indications where you have to do vitrectomy as quickly as possible. Now, coming to anti-VEGF, pre-treatment with anti-VEGFs has helped us a lot. That is one of the change that has helped vitreous surgeons a lot in diabetic vitrectomy. And usually we give anti-VEGF about 3 to 4 days prior to 5 days prior to surgery, especially in cases with florid and active neovascularization. One word again of caution is that before you give anti-VEGF, you make sure that your patient is fit for surgery. So otherwise, in some of the cases, you can land up with worsening of tractional detachment. So what anti-VEGF does is it helps in reducing the incidence of intraoperative bleed and use of endodiathermy. It also reduces the surgical time and also helps in reducing the post-operative vitreous cavity bleed. So anti-VEGFs before diabetic vitrectomy has come up in a very large way. So goals of pars-plana vitrectomy in patients with advanced PDR would be to first is to clear the medium. Second is to relieve the anterior, posterior, and the tangential traction, the tractions because of the membranes themselves. You have to achieve hemostasis. You have to seal all the leaking, oozing vessels. And most importantly, you have to do PRP. So that's one thing that you should always remember. The techniques, although the technology has evolved over a period, over say, last few decades, the techniques have by and large remained the same. And what we essentially do is two things. One is we segment a large membrane into smaller segments. So you use the cutter, or you can use your vertical scissors or horizontal scissors, whatever you use. You basically divide the membrane into several small segments and then eat it up. So that is segmentation. And delamination is when you remove the anterior posterior traction and then go in, lift the membrane, and you cut each of the pegs with the cutter or with your bimanual forceps and scissors. So these are basic two techniques that you should know that we do in when we operate these eyes. The outcomes, generally the anatomical outcomes are good in most of the cases, but however the visual outcomes can vary, and it depends upon the status of the macula, how long it has remained detached, and probably in patients with tractional detachment, one of the most important predictive factor for postoperative visual acuity would be the presenting visual acuity. So to summarize, PDR is a sight-threatening complication of diabetic retinopathy, mainly driven by VEGF. PRP still remains the standard of care in most of the patients. Anti-VEGFs can be used as an adjunct or in combination of PRP in patients with PDR and DME. And PPV is usually done for non-resolving vitreous hemorrhage, TRD, or a macular threatening TRD. So thank you so much for your kind attention, and I'll be happy to answer some of the questions that may come.
Thank you so much, Dr. Alok, for the wonderful presentation. I'm Dr. Shishir Agarwal, Chairman. Sorry, I joined a little late. I would like to thank Dr. Praful for the wonderful session. Dr. Alok has covered practically everything in PDR, and it's a good lecture for the PGs. So the important point I'll say is, when to do an early PRP, a case whose one eye has been lost. So it is very important, and in pregnant cases, to do an early laser. And yes, in the times when the anti-VEGFs had just initially come, people used to inject anti-VEGFs, and there would be tractional detachments and whole sort of problems. So it is very important that you monitor that. And yes, the laser is the treatment finally, because anti-VEGFs are temporarily working, and you have to finally give the laser. So thank you so much, Dr. Alok.
Thank you, sir. Thank
And so I think we go on to the next lecture. This is by Dr. Vineet Batwani from his SR from AIMS, Delhi. Dr. Vineet, please. Dr. Vineet is there.
I think, sir, I cannot see him on the list. We might need to next lecture.
Right, please.
Vineet. Yeah, Dr. Vineet is here.
Yeah.
In the timing he prepares himself, I would go. Let's go to my lecture, sir.
Yeah,
I would be talking about
sure.
BRV. Yeah.
Yeah, please go ahead, Dr. Ankur.
Yeah. So just allow me to share my screen.
Can I ask Dr. Alok as to which anti-VEGF do you usually use before a vitrectomy?
So, sir, we usually use the nowadays biosimilars that are available.
Right.
Here we were using Avastin because anyways you are operating. So,
Correct.
Nowadays we are using biosimilars, ranibizumab biosimilars.
Right. Okay. Because all these will give the same effect, because these have to be used just for the surgery point of view.
Yes, sir. Yes, sir. Absolutely.
Correct. Thank you.
So is my screen visible?
Yeah, it's visible.
Yeah. Very good evening, everyone. So I'm going to talk about BRVO. And why? Because it is the second most important vascular occlusion after diabetic retinopathy, which we have covered, and is often associated with vision loss. There could be partial or complete obstruction of a retinal vein, and it is classified based on the location. So I'm going to cover BRVO. Then you should also know about that if the thrombus is at the central retinal vein near lamina, it is CRVO. It is at the persistent vestigial bifurcation in the retrolaminar portion. It is the hemicentral retinal venous occlusion. And if it happens at the AV crossing, it is a BRVO. So for any disease, there are risk factors. And the risk factors in this is the high body mass index, systemic arterial hypertension, diabetes mellitus, open angle glaucoma, hyperlipidemia, cardiovascular disease, hypercoagulability, and hypothyroidism, and cigarette smoking. So these are many in number. So there are certain risk factors which are to be understood when you're looking at a patient profile more than 40. The important ones are high body mass index, hyperlipidemia, hypertension, because the disease usually occurs between 5th to 7th decade. So BRVO is more common than CRVO in epidemiology. The prevalence is 4.42 per 1,000 adults. It is strongly associated with systemic vascular disease, which I've just discussed, that is hypertension that leads to atherosclerosis. Most frequently in 60 to 70-year age group, and men and women are affected in the same way. So we should understand how does it happen. So if you see when there's an atherosclerosis, is the thickening of the atrial walls, it compresses over the vein. So once the systemic hypertension leads to atherosclerosis, the compression, because they share the common adventitious sheath, this lead to turbulent blood flow over here in the vein. And this turbulent blood flow, because this kicks in the Vicos triad and leads to the coagulation at the AV crossing, leading to occlusion of that vessel at that particular place. And when there is an occlusion, it leads to the elevation of the venous pressure on the distal end, leading to intraretinal hemorrhages, macular edema, and ischemia. And what these leads to is sudden painless loss of vision, as well as the visual fields in the affected quadrants are affected. However, in subclinical cases, when the macula is not involved, you don't have a macular edema, or the hemorrhages are not abutting the fovea, you can have a patient which does not have any decrease in the vision, but still be affected with BRVO. Sometimes these patient comes late, and when they comes, they have the aftermath of BRVO, that they have neovascularization elsewhere, leading to vitreous hemorrhage, and they can come to you with flotters, which are nothing but the blood in the vitreous. So how do you see this? You see them as wedge-shaped intraretinal hemorrhage. What you see over here is an inferior temporal BRVO, and you see here are the flame-shaped hemorrhages. Apart from these, you see those cottonwool spots. You see tortuous vessels which are dilated, veins in this case, and you see subtle decrease in the foveal reflex. So for postgraduate, if the question is asked, which is the most common quadrant for BRVO, you need to answer that it is superior temporal quadrant. So how can a patient present to you? So patient can present to you at different stages. One, it can present to you with a fresh macular or inferior temporal or superior temporal BRVO. What you see over here is when the macular arcade are involved, you see hemorrhages abutting the fovea, and this can lead to decrease in vision, not even though the patient does not have macular edema. So these patients are summed up as macular BRVO. Then they may come late to you. They may come with later in the course of the disease, and this time they might be having new NVEs, and this is how it looks. You see these leaky vessels and FFA. So that can happen in 31 to 41% patients of ischemic BRVO. So you need to understand how do you differentiate. BVUS study differentiated ischemic and non-ischemic BRVO based on the amount of non-perfusion area. So if the non-perfusion area, these are the non-perfusion area that you see, if you are able to see my pointer, all this area, if it is more than 5 this diameter, you are looking at a ischemic BRVO. If the patient goes into the second stage or the later stage, these NV can bleed and the patient can comes to you at a vitreous hemorrhage, and you may identify the BRVO during your vitrectomy. And then sometimes, patients go back to normal because this is a disease which has a good prognosis. And these patients is where you see these kind of collaterals. These collaterals are developed because they are trying to vascularize the retina, which has become non-perfused, as well as you see these ghost vessels. If you see, these are the ghost vessels, and they tell the sign that they were the veins at the time in the past, and now they have lost their flow. So now they you just look at the wall of these veins, which are seen as silver ghost vessels. So prognosis I've already discussed is a good prognosis. So which are the patients who have bad prognosis? Bad prognosis patients are the patients which have chronic macular edema, or the fovea is knocked out. The macular ischemia is there. The CNP area is abutting on the macula, the fovea, so it is leading to ischemic macular edema. And certain times these patients have vitreomacular tection or ERM. So as a postgraduate, when this patient comes to you, what you should do is you should do a complete ophthalmic examination. But what is important for you primarily is to see for pupillary reaction. Although in BRVO, it is less commonly affected compared to CRVOs, but you need to assess the pupillary reaction in this patient. You need to see the IOP. You need to do a complete slit lab examination. And apart from that, what is important for you is that this patient should be sent for, and after fundus examination, if you diagnose a BRVO, he should be sent for OCT, which is going to help you to quantify the macular edema. Do an FFA, you will be FFA, but later in the disease process, then you will be able to see those CNP areas, and you will be able to know that this patient has ischemic or non-ischemic CRVO. Apart from that, The basic investigation that you have to do, which are primarily important, are the fasting lipid profile, the blood pressure of the patient, because most of the time these patients are just hypertensive. And if the patient who is coming less than 50 years of age, you need to think of other problems like blood dyscrasis, where there could be an altered serum protein, or hypercoagulable state where the patient has altered homocysteine or factor of 5 later mutations. So you don't need to do these investigations in all of the patients. Sometimes the patient now what has happened is the lipid derangement has come down to a lower age also. So there are patients who are presenting with the same metabolic problems which used to happen in older age, but they are coming now earlier. So because the profile of disease, the hypertension and the diabetes have moved down. But you need to understand that the disease, the hypertension needs to take some time. It has to be there for some time for the atherosclerosis to happen, and that is when the BRVO occurs. So apart from apart from what we have discussed, you also should know that there is an inflammatory BRVOs. And inflammatory BRVOs happens when there is vasculitis, and vasculitis by per se can lead to BRVO. So what you see over here is this perivenous infiltrates, and these infiltrates are leading to BRVO. And the most common cause of this inflammatory BRVO in Indian context that you should know is tuberculosis. So what this hypoxic and this increase in venous stasis leads to is macular edema, neovascularization, and vitreous hemorrhage. So what does the study tells us? What you should know about the studies and how do you treat these patients? So BVOS, the BVOS study, which is important, told us that the scatter laser is only indicated when neovascularization develops. So before even if you see those CNP areas and the neovascularization has not happened, you don't need to do scatter laser. Previously, there was something known as macular grid lasers. And the treatment that used to be given previously with the macular grid laser used to start at the end of 3 months. But now the primary mode of treatment, if anybody asks you now, is anti-VEGF. So anti-VEGFs can be ranibizumab, or which the study that you should know is Bravo study. It could be aflibercept, then the study you should know is Vibrant study, or bevacizumab, then the study you should know is Vibrant study. The newer salt, which is biogenic antibody, is the anti-VEGF that you should know about is faricimab, and the study that you should know is Balaton study. And you should know that certain patients in BRVO also require surgical intervention. One is vitreous hemorrhage, or if they develop an ERM, that is pars plana vitrectomy for these patients. And the surgery depends on the pathology. So you can also use steroids. Steroids can be used in the form of triamcinolone or Ozurdex. Ozurdex is a long-acting dexamethasone implant, which have an effect usually for 1 to 3 months, usually 3 months, and it leads to faster visual improvement. And when you talk about triamcinolone, you need to know about SCORE study because it tells you the dosage of triamcinolone that you have to use, and you should know that the 4 mg dose that were used in the study led to more cataract cases and IOP risk. So how do you follow up these patients? So if there is a recent event of BRVO, then there is a monthly follow-up because you need to inject this patient monthly if the patient has a macular edema. If the patient does not have macular edema, he presents to you late, he has a stable BRVO, then you need to follow them every 3 to 6 months, keep checking for macular edema recurrences or neovascularization elsewhere. If the patient is having ischemic BRVO, but ischemic BRVO means that the patient who has more than 5 disc diameter capillary dropout, but has no active macular edema, then the follow-up is every 3 months. Why it is important? Because you want to rule out the aftermath. Aftermath can be the vitreous hemorrhage that can happen because of the NVE, or sometimes you need to do gonioscopy in these patients to look for any NVE or NVA. And FFA, of course, is required, and IOP, because these patients can also develop, not with as much as in CRVO, but these patients can also develop neovascular glaucoma. So now just see this case. So this patient presented to us he was a hypertensive patient who presented to us with inferior temporal BRVO. And what you see over here is those flame-shaped hemorrhages, which I've just described. Look at the OCT. So in OCT, you see those intraretinal cystic spaces with some subretinal fluid. So this is this is how you see CME. And with the BRVO picture, with the CME here, probably you are looking at a macular edema secondary to a BRVO. You inject this patient, as we did in this patient, you see with the systemic control and the anti-VEGF, you see the resolution of those hemorrhages which were here has gone down. You see the cortical wool spot have not increased. So what you see, it is these cortical wool spots was there, if you see over here, and now you can see them more. The time with the metabolic control, they will also go away. And you see the intraretinal cystic spaces are gone, but the subretinal fluid is still present. But with time, the retina, the fovea has achieved the normal contour, and the patient has achieved the visual acuity of 6/6 partial. So you see a patient which came with 6/60 with the anti-VEGF can be treated, can achieve 6/6, which is near normal vision. So that's all I wanted to share about BRVO. Thank you. Thank you for your patient hearing.
Thank you, Dr. Ankur. It was a wonderful presentation for the PGs and practically everything covered for BRVOs and CRVOs. Would like to stress a couple of points that anti-VEGFs is the first line of treatment whenever there's macular edema. So you give the anti-VEGFs and it settles down, the vision improves, and wherever there is a recurring edema and in BRVOs, you can always do a sector laser in those cases. And the inflammatory vein occlusions you just touched upon, there's a condition, a rare condition called papillophlebitis, where there could be a CRVO because of inflammatory reasons, and tuberculosis has to be ruled out, and other connective tissue diseases. And a course of steroid in such cases, besides treating the primary cause like tuberculosis, it works wonders, and you can get a practically normal vision in a CRVO patient, which is inflammatory. It is called papillophlebitis, is a rare condition. Thank you so much.
Thank you, sir.
Thank you, Dr. Ankur. I'm sorry I joined little late today because we had a meeting with health secretary on a very important issue for our private practitioner, that is CGHS empanelment. So although I won't say welcome all. So thank you all students. You have joined in huge number. I hope the session is going fine and it will be fruitful to all of you. And thank you, Sisir sir, for joining as a chairperson. And Dr. Ankur, I think you help to carry forward the sessions. So I'm here. If anything is required, then you can just drop me a message. I'll be there. And time is a limiting factor, Dr. Ankur. So because we have 19 talks and 10 minutes each, so I would suggest keep all the discussion after the lectures are over, or maybe one or two salient points from the chairpersons, respective chairpersons. Right, Dr. Ankur?
Perfectly fine, sir.
No. Thank you so much. And please, moderators and chairpersons, thank you so much. Please carry forward the session.
Thank you, sir. So we go to the next talk, for the next talk, which is important topic, that is CRVO, central retinal venous occlusion. For this, we have Dr. Deepa. Dr. Deepa, are you there? Okay. As I think we can go to the next talk. That is another important topic, that is central retinal artery occlusion, CRAO. Dr. Shweta, you are here with us.
Yes, sir, I'm here.
Yeah.
Just give me 1 second to share
Please,
the
please.
presentation.
Sir, meanwhile, Dr. Shweta puts up his slides. What do you think? Do you have any thing that you want to share about the topics covered till now? There have been talks on diabetic retinopathy, something that residents should know. Sashish, sir?
Yeah. So from BR, so anti-VEGF today is the first line of treatment treatment in diabetics, usually the macular edema is the presenting thing. So various studies you should know, and the criteria for macular edema and when to give the anti-VEGFs. We have biosimilars now. So we had started with Avastin, bevacizumab, and ranibizumab, and aflibercept now, and the newer ones. They can prolong the interval between the two injections. So, and from the proliferative cases, PDRs. So, when you have to do an early laser, that is important. Dr. Alok's lecture was very important. He had discussed the important points. You should remember those, and when to do early laser. And yes, that the anti-VEGFs, this is a temporary treatment, and you should be careful in a case which has aggressive PDR with TRDs. You give anti-VEGF and it can precipitate detachments. So you have to be careful, and you do laser, then give anti-VEGFs. And anti-VEGFs would be a temporary treatment. Finally, the laser has to be done in proliferative cases. This is the final treatment. So in the era of anti-VEGF, so many times the laser is avoided, is not done, but that is not the right thing, because finally it is the laser which will regress all the vessels permanently, is the important thing.
So the protocol is just to be read, not to be followed.
Correct.
Yeah.
So, I mean, practically, these are the important points.
Thank you, sir. Ma'am, can you just
Yes,
share?
yes, sir. Yes, sir. Um, are you able to see my screen with the
Yes,
PPT?
yes.
Okay. All right. So good evening, everyone, and thank you, Professor Sir, for the wonderful opportunity. So I'm Dr. Shweta, and I'm going to be talking about central retinal artery occlusion. Now, this is an extremely important topic, not just for exams, because in theory you can be asked, and in practicals you might be given most probably a chronic CRAO. But it's very important in life, not just as an ophthalmologist, but as a doctor as well. So just a brief word about the relevant anatomy. So the central retinal artery arises from the ophthalmic artery, which is a branch of the internal carotid artery, and it supplies the inner 2/3 or the inner 6 layers of the retina. So this is again one of the things that we can credit to being described by Van Graaff as early as the 19th century. Men are affected more frequently than women, and in general, 90% of cases occur over the age of 40 years. So how does the central retinal artery get occluded? So it can be either from an embolus, either from the carotid or the heart, or from a thrombus itself, which is relatively rarer. So the causes, now all the causes of vascular occlusion were mentioned in previous presentations. So I'm not going to be repeating it, but then there are some extra causes like valvular diseases and atrial fibrillation. So in general, when you're presenting the causes, you have to say the causes in general and also additional causes depending on the age of the person, like old or young. Young is generally considered less than 55 years of age. And you can classify them as vascular, metabolic, and so on. So, what are the types of emboli that we see? So, the most common type of embolus that we see is the cholesterol plaque. So, that occurs in about 75% of cases, and these occur as refractile yellowish crystals, most commonly seen at the bifurcation site. So, the next most common is fibrin plaques. These are slightly more whitish, kind of translucent almost, and they are multiple, and you can see that they are mobile. After that, we see calcific, which are actual bright white plaques. And lesser, rather very rare causes are fat emboli, tumor, amniotic fluid, and bacterial vegetations. So these are some pictures. You can see on the right side is a calcific plaque. Top left is a cholesterol plaque, which is typically at a bifurcation site. And in below, you can see the fibrin plaque. So these are again see such an extensive battery of causes, possible causes in young CRAO, and all of these are extremely important because in a CRAO, our main work as an ophthalmologist is to ensure that it doesn't find the systemic cause under it and ensure that it doesn't happen again in the other eye or in other vasculature of the body. So these are the most common causes, but in the Indian population, the most common causes are hyperhomocystinemia, coagulation disorders, OCP usage, and hemoglobinopathies. And then SARS-CoV-2 has also thrown a spanner in the works. So there is increased inflammation because of the virus. So the endothelial cells get activated, causing platelet activation and stasis. This causes elevated D-dimer levels, thereby thrombocytopenia and hypercoagulability. So what actually happens in central retinal artery occlusion? There's acute obstruction of the retinal artery. So there's secondary collapse of the capillary blood flow. This in turn causes axoplasmic stasis, which increases intracellular edema and thereby ischemic necrosis of the inner retina. And then you can see finally the cherry red spot, which is seen through the thin foveola as the choroidal circulation is intact. So the types of CRAO that we commonly see, they were described by Dr. Here, broadly classified into arthritic and non-arthritic. Non-arthritic is further classified into permanent, transient, and with cilioretinal artery sparing. So the reason this is important is mainly for prognostication. Arthritic has the worst prognosis and thankfully it's the least common. So it can also lead to no PLIs, and this can most common cause is giant cell arteritis, and it can also most commonly cause ophthalmic artery occlusion. In non-arthritic, the most common type is the permanent non-arthritic type. And then you also have a transient non-arthritic CRAO, which is similar to a TIA. And because of the transient impact of the embolus, the perfusion pressure falls, which causes the temporary symptoms. And with cilioretinal artery sparing, the cilioretinal artery is seen in about half of the population, and it supplies the macula actually in varying capacities. And depending on the area of supply, the visual acuity is quite well maintained. So this is a case of a CRAO with cilioretinal artery sparing. You can see a nice orange healthy looking band in the center of the posterior pole, and that is the area that's typically around the cilioretinal artery, and you can see the area around it is whitish, and some of the areas have started opacifying also because of the stasis and the edema. And so this is also shown more beautifully on the FFA on the right. So just a quick note on giant cell arteritis, because that is the most common cause of arthritic CRAO. So it is a painful sudden loss of vision in case of giant cell arteritis. Pain in the sense that it could be associated with scalp tenderness, jaw claudication, and also with arthritic AION. Now, the reason this is very important is because it can be bilateral and it can cause blindness, and it is preventable. So that is the reason this needs to be recognized faster. So what are the clinical features of central retinal artery occlusion? Sudden profound loss of vision. Amaurosis fugax might occur. That is, there can be transient vision loss, more commonly seen in the transient non-arthritic types. And if it's due to arterial spasm, some patients may even present with relapsing and remitting course of visual loss. Definitely the patient has an RAPD, and rubiosis iritis may be present. So if you see it immediately, suspect ocular ischemic syndrome. If you're seeing the patient much later, it could be a neovascular complication, although NVE and NVD are more common in CRAO. And the IOP, if the rubiosis turns into neovascular glaucoma, can be higher. This examination, the first thing, of course, that's jumping out at us is the cherry red spot. And that, like I said, is because of the intact choroidal circulation through the thin foveola. Then you can also see peripapillary edema and whitening. There can be splinter hemorrhages. So in these cases, always try to look for the emboli. These are visible in about 20% of cases. And also try to assess for the presence of a cilioretinal artery, because if you do look for these and mention these, it does show that you've done a comprehensive examination. In arthritic CRAO, there can also be AION associated. And but very often in the exams, you're only going to be getting a chronic CRAO, in which case there'll be optic atrophy and with severe arterial attenuation, and there may be neovascularization. So this is a picture on the left showing where you can see the plaque, and you can also see the NVD. On the right, you can see the whole pale edematous retina with multiple tiny plaques and cherry red spot. So what are the investigations that you do? Actually, CRAO is largely a clinical diagnosis. As soon as you see, you can pick it up, but the FFA does add some points which can give us further details like areas of necrosis, and to mainly assess if there's a cilioretinal artery and if that is spared. And also, if you can see that the choroidal as well as retinal circulation is compromised, then that is you're looking more at an ophthalmic artery occlusion. Over here you can see on the right side that even the choroidal filling is very patchy, and on the top right you can see that there's cilioretinal artery sparing. So when you do an OCT in the acute phases, you can see hyperreflective inner retinal layers with loss of the regular foveal contour. So an optical intensity ratio is a ratio that is used to is used for prognosticating. So you have to take a ratio of the inner hyperfluorescent ischemic layers to the PRRP layers of the outer retina. So a higher ratio indicates a poorer prognosis. That is because it indicates areas of greater ischemia. And in chronic cases, when you see like a diffuse thinned out retina, which has lost its retinal architecture in the picture below, and it has lost its foveal contour. OCT angiography is just shows you further disruption of blood supply in the superficial and deep plexus, more marked in the superficial plexus. So visual field changes, sometimes central scotoma, and some parts of the peripheries may recover in non-arthritic cases. ERG, very important to remember that the B wave is reduced and A wave is preserved because A wave is from the outer retina and B wave is from the inner retina. Systemic workup is extremely important. Like I said, our main job is to make sure that it doesn't occur again in the other eye and do other parts of the body. So you have to do a detailed and very extensive battery of tests, especially if the patient is young. Not a single test can be excluded. So the list of tests is over here. So prognostication, the one take home message that I want you to take from my talk is 90 minutes. 90 minutes is the golden period by that is the amount of time that the retina can tolerate ischemia. So whatever intervention that we do, if the patient has been lucky enough to present to you within 90 minutes, please follow the treatment protocols. I'll describe them subsequently. But 90 minutes is the golden period. Some improvement is possible until 240 minutes, but beyond that, not much else can be done. So what are our goals of treatment is to dislodge the embolus and ensure that perfusion is restored as early as possible. So what do we do as soon as we suspect CRAO? So first thing, carbogen inhalation. So carbogen is a 95% oxygen and 5% carbon dioxide. So because of the higher percentage of carbon dioxide, you ask the patient to breathe into a paper bag or into their own cupped hands. So what happens is because of this higher carbon dioxide concentration, there occurs vasodilatation. Next thing that you should do is start giving digital massage. So you can do this either with your fingers. Some authors describe doing this with a gonio lens. So give firm digital massage for 10 to 15 seconds and then suddenly release. So this causes like a sudden reduction of IOP. Then next thing you can do is paracentesis to remove about 0.2 cc of aqueous. Of course, there are lots of controversies surrounding this. But this also suddenly reduces the IOP. So the aim behind suddenly reducing the IOP is to dislodge the embolus to a more distal site. So these measures should be continued at least for 15 to 20 minutes. You can also give sublingual sorbitrate, nitroglycerin patches, or IV acetazolamide. So after 15 to 20 minutes, we have to reassess vision and see if the embolus has been dislodged. Other things that can be done are topical anti-glaucoma medicines like apraclonidine and timolol, hyperosmotic agents such as mannitol or glycerol, hyperbaric oxygen, again 95% oxygen and carbon dioxide. Transluminal YAG laser embolectomy has been tried to dissolve the embolus. And if you suspect arthritic CRAO, please immediately start the patient on steroids. Anticoagulants in case of hypercoagulable states to prevent from further stroke. So thrombolysis was attempted. Eagle study was done in which thrombolysis was attempted in cases of CRAO. So intraarterial intravenous thrombolytic streptokinase was given. And although vision did improve from this thrombolysis, the morbidity rate was found to be much higher, leading to intracerebral hemorrhage. So this is actually not routinely done anymore. So just my take home points from this and questions that might be frequently asked are that first remember that 90 minutes is the golden period before which we can restore good vision for the patient. Second thing, the investigations are very important. You have to remember how to investigate And the third thing, just how to explain prognosis and to ensure that this doesn't happen again in the subsequent, in the other eye or in the rest of the systemic evaluation. Thank you.
Thank you so much, Dr. Sweta, for the nice talk. Covered everything for the artery occlusions. So in CRAOs, an acute case, cherry red spot, and you'd be able to see on fundus examination, as you rightly said. And uh, in long-standing cases, you would just see a pale disc, and maybe if it is not too pale, then you just have to take the history and find it out. And usually, so you have to know as to what you have to do in that golden period, the first, as you pointed out, the first 90 minutes, all the measures have to be taken. But practically, usually the CRAO, it does not open. So that is the thing. Thank you so much, Dr. Sweta.
Thank you, sir.
We can have the next talk now, Dr. Ankur.
Yeah. So for the next talk, we have Dr. Sangeeta, who would be joining us from MNI Hospital, Chennai. Ma'am, you can share your slide, please.
Yes, yes. Sir, is my slides visible?
Absolutely,
Yeah.
ma'am. They're looking good.
Okay. Okay, good evening and thank you for the opportunity. So I will be giving a short talk on the central serous chorioretinopathy, and it is one of the most common non-surgical cause of maculopathy apart from the diabetic macular edema and the wet AMD. So a short glimpse into the history. Again, it was Dr. Van Crafty in 1866 who has identified this disease as relapsing central lutic retinitis. And later on, there have been multiple terminologies has been proposed, and the serous term was added by Dr. Horniger. And the current term, the central serous chorioretinopathy, was coined by Dr. Gass in 1967. So what is CSCR? It is the serous detachment of the neurosensory retina with or without a pigment epithelial detachment. It is usually unilateral and typically occurs in males around the age of 20 to 50 years. So the risk factors, the first one goes to the steroids, either exogenous or endogenous. Exogenous in the form of medications, it could be oral, topical, or inhalational. The endogenous being the stress, and also people with type A behavior, hypertension, H. pylori infection, sleeping disturbance, and autoimmune disturbance have also been assessed as the risk factors, but the main factor being the cortisol. The exact pathophysiology remains still unclear, but the most commonly accepted theory is the hypercortisolism, which makes the choriocapillaries or the choroidal blood vessels to be more sensitive to the catecholamines like epinephrine or norepinephrine, causing the choroidal vessel vasoconstriction, choroidal ischemia, increased intraluminal hydrostatic pressure, and hyperpermeability of the choriocapillaries, which in turn causes the RPE decompensation, allowing the choroidal fluid. So there occurs a SRF accumulation causing the CSCR. And now we all know that it's a part of the broader pachychoroid spectrum, further adding to the disease complexity. So the commonly used classification by the clinicians include acute and chronic. Acute lasts for 3 to 6 months. The chronic is a CSR that prolongs more than 6 months' time. Because of the lack of a consensus, the CSCR International Group has proposed a classification: simple, complex, and atypical. The simple and complex is basically around the area of the area of the RPE atrophy or the RPE dysfunction, and they are further classified as the primary, recurrent, or resolved. And next comes the atypical, which means the bullous retinal detachment and the bullous bullous CSR, or the CSR with an RPE tear or CSR occurring secondary to other retinal diseases. The patient usually presents with the central scotoma and also with metamorphopsia and micropsia. Usually what we see in the clinic is a hyperopic shift, what we also called as the hypermetropization, which means they usually accept around plus 1.5 or 1 diopters for their visual correction. There is also loss of contrast sensitivity and some color vision as well. The Clinical features is usually is easily made out with the slit lamp biomicroscope or an IDO. We could see a good macular edema, but make sure we are looking into the margins, because an inferior retinal detachment can be easily taken up as an CSCR if it is involving the macula. So look for all the margins, and also have an optic nerve assessment to rule out the optic nerve pit. And look for signs of chronicity like the subretinal precipitates or the RPE tracks as shown in the above picture. Usually we put the patient, I mean, it is not, the imaging is not for the diagnosis, but to know the prognosis and the management. Coming to the multimodal imaging, first I would describe on the OCT, which is a primary imaging tool. And in OCT, we see a subretinal serous fluid in case of CSCR. And also in chronic, we see the subretinal precipitates, and in chronic resolved CSCR, there could be loss of the ISOS junction or the disturbance of the ellipsoid zone. And this is again a case of an CSCR, chronic CSCR with RPE tracks and multiple shitic spaces. All these are pro-prognostic factors and indicate chronicity. Autofluorescence has always been interesting imaging in the CSCR. And in acute CSCR without any RPE disturbances, usually they show a mild hypofluorescence along the SRF. So once the RPE is disturbed, and we can see area of hyperfluorescence, hyperautofluorescence. So whenever the RPE is stressed, we usually see a hyperautofluorescence. Whenever there is an RPE death, the RPE loss, we see a hypoautofluorescence. The second image shows multiple areas of hyperautofluorescence corresponding to the subretinal precipitates. Usually they are the phagocytosed outer segments of the photoreceptors. And this is again a chronic resolved CSCR with multiple areas of RPE atrophy shown as the hypoautofluorescence. The gold standard still is the fundus fluorescent angiogram to know the leakage and the location of leakage. And for exam purpose, we definitely need to know the two types of common leakage, the ink blot and the smokestack. The ink blot is nothing but so sorry, some would hear some noise.
Hello.
I am able to hear some other video that is running. I'm not sure.
There's some problem with your connection.
My connection, sir?
Yeah, not able to properly. There's some.
Ma'am, I think your screen, you have just opened up all your screens. You need to just go back to just maximize your PPT wali screen. This is a Mac. Go to the green one. Maximize your PPT screen. You can share it again, ma'am.
Yeah, one. Ankur, you want me to share the slides?
I think, ma'am, slides.
देखते हैं, we'll wait.
Yeah. So we'll wait for about half a minute if ma'am still.
No worries, no worries.
Yeah. Sangeeta ma'am, you can just reshare it. I can see you live over here. You can just share your screen back. Yeah, it is visible now. Go to this green thing. Yeah, you are back again. Perfectly fine, ma'am. Ma'am, please switch on your mic. You are not audible. Yes. Very good.
So the ink blot type of leakage is nothing but a pinpoint leakage that increases in intensity as well as the size during the late phase. And the next common is the smokestack. Smokestack is nothing but the rising like a mushroom type of fluorescence. That is because of the difference in the protein gradient between the subretinal fluid and the leaking fluid. So this usually occurs because of the current. Sometimes we can see more than one leaking areas on the FFA. The picture on the left side is the acute CSCR and the blue autofluorescence, which is quite insignificant. And in the late angiogram, we can see two pinpoint hyperfluorescent areas, the leakage, and early ICG is quite normal. And in the mid ICGA, we can see the corresponding leakage through the corresponding to the FFA. And in the chronic CSR on the left side, on the right side, the blue autofluorescence shows some areas of hyperautofluorescence that corresponds to the RPE disturbance that is seen. And the late FFA shows pinpoint leakage shown on the red and some areas of hyperfluorescence corresponding to the fundus, the autofluorescence, that is the RPE disturbance. And the early ICGA shows here the dilated choroidal vessels. The late one shows a pinpoint leakage on the superior arcade. That is corresponding to the FFA, and there are some areas of mid-phase hyperfluorescent plaques, and this is a marker of the chronic RPE dysfunction. And the differential diagnosis include the pachychoroid spectrum, optic nerve head prick, VKH, APM, PPE, and choroidal tumors. So acute cases, masterly inactivity, that is just observe the patient or maybe a placebo treatment. And we have to make sure the patient is off the steroid therapy, and the stress management, sleep cycle should be emphasized. The spontaneous resolution usually occurs in 8 to 12 weeks time. And there has been some topics on, some role of topical NSAIDs and topical carbonic anhydrase inhibitors. For topical NSAIDs, there is no much evidence supporting the use of NSAID for CSCR, and on long-term use, it could have some undesirable side effects on the cornea. The topical carbonic anhydrase inhibitors have shown in some studies, especially in chronic CSCR, to have some reduction in the central macular thickness compared to the observation. And now coming to the management of chronic or the recurrent CSCR, there is no proper guidelines, but there has been various medical therapy that has been tried, like anticorticosteroids, rifampicin, ketoconazole, finasteride, and H. pylori treatment. And all of it is lacking proper evidence. Anti-VEGF therapy, the CSR is actually not VEGF driven, but if the patient responds, then probably it could be a spectrum of the pachychoroid. Then comes the laser photocoagulation and the PDT. So focal laser, we usually do focal laser for leaks that are 500 microns away from the foveal center. So we don't give a full burn, we just do a mild focal laser, which is almost called as like a photofermentation, just to seal the micro breaks in the RPE, and it is guided by FFA. We have to inform the patient that it is not going to resolve suddenly the next day. It may take almost 4 weeks for complete resolution. So the down picture, the central one shows a subfoveal leak, which is not an ideal candidate for the focal laser. The subthreshold micropulse laser has been widely used with 55% duty cycles and 200 milliseconds pulse duration with 100 to 200 micron spot size for the CSCR leak. The PDT has been very successful in the treatment of CSCR, but unfortunately, the medicine is not more available in India. What we use is the vertiporfin, the photosensitizing agent. The full dose is 6 milligram per meter square, and the full fluence includes 50 joules per centimeter square for 83 seconds. And the benefits have been equally studied in half dose and half fluence PDT. And we have to know this for exam purpose, though it is not being available to us now in India. Now, lastly, coming to the pachychoroid spectrum, we know that the pachychoroid spectrum consists of CSCR, pachychoroid pigment epitheliopathy, pachychoroid neovasculopathy, and PCV. So when we have a choroidal thickness on an EDA or on subsource OCT more than 300 to 350 microns with a large dilated hallux layer compressing the sacklers and the choriocapillaries, then we know the CSCR is most probably from the pachychoroid. And some subtle signs on the OCT, like the double layer sign or double hump sign, could indicate that the CSCR could be a part of pachychoroid. So to conclude, the CSCR is due to the accumulation of the subretinal fluid. The main pathophysiology that is accepted by everyone being the cortisol. The clinical features are easily made out with slit-lamp biomicroscopy, but multimodal imaging will help us for management in non-resolving cases. Acute cases we usually observe, and in chronic cases, medical therapy has been tried, and laser still has a role. And remember, the CSCR can always be a part of pachychoroid spectrum. Thank you.
Thank you so much, Dr. Sangeeta. Nicely covered the whole of it. So, from the PG's point of view, you see a patient in the OPD, a young male typically, and his one eye is 6/6, the other eye is with maybe plus 1.25 improving to 6.9. So, in a busy OPD, you might miss that case. So, you just dilate C with indirect a round lesion, and so many times an inferior detachment. You have a macular involvement. You sometimes put it to be a CSR, so you have to be very careful in a busy OPD, and you have to properly do an indirect examination. And the main treatment is no treatment at all. And in chronic cases, initially it used to be called type 1, type 2, and type 2 usually it used to be said was because of COX, and antitubercular used to be given. But now the concepts have changed, and for chronic cases there is problem, and laser and subthreshold micropulse laser and the other things have to be done. Thank you so much.
Yes, thank you, sir.
You can have the next speaker.
Ankur, just add on screen share for me. Ankur,
क्या हुआ? What's the issue?
can you give me a command for screen share? Is my screen visible?
Somebody has to stop it, I think. Who is sharing this screen?
Is my screen visible, Prafulla?
No, it is not.
Yeah. Now is it visible?
Yeah, visible now.
Okay, thank you. Many thanks for the kind invitation once again, and imperative to talk on macular holes, which also includes some form of vitromacular traction. And we will be going through the olden day classifications, the recent ones, and few newer techniques which have changed the management of macular holes, which as postgraduates and fellows we should know in the recent era. No financial disclosure in my talk, but just when we see why macular hole surgeries or macular surgeries per se has changed or evolved over a period of time, especially in the last 1 decade, is in the era of high-speed vitrectomy cutter systems, giving us more precision, more accuracy, and better outcomes for our patients, giving them almost 6/6 or 20/20 vision. So a lot of things have changed in the surgical armament area in these two disorders, both vitromacular traction and macular holes, in form of vitreous removals, which is very effective. Surgical versatility offering us, we are offering surgeries to patients who have 6/9, 6/12 vision, and also giving us very improved fluidic stability, which gives us a lot of benefit, and enhanced stability, procedural efficiency, and improved precision. So over a period of time, a lot of things have changed and evolved. And also we have newer, membrane peeling forceps, which have made all these surgeries quite simpler and less demanding, and giving better anatomical and functional outcome for our patients. So let's see, what do we mean by vitromacular interface disorders? There are 4 of them. First thing is called as vitromacular adhesion, VMA. Then we have vitromacular traction, that is VMT. Then we have epiretinal membrane formation, and we have macular holes, which can be lamellar holes or full thickness macular holes. So if I simplify to understand, we have vitromacular adhesion, which is where the posterior cortical vitreous is attached to the center of the fovea, especially into 2 to 3 millimeter zone. There are no secondary changes in the retinal layers. It can be focal or it can be little broad-based, and you may have underlying macular pathology associated, especially originating from the choroid, but the retinal layers are still intact. So this is vitromacular adhesion. Then vitreomacular traction, though this is an extreme case, but there is a perifoveal vitreous cortical separation, or it is happening from the central retinal surface. The vitreous attachment is again in the 2 to 3 millimeter zone from the center of the fovea. It distorts the foveal architecture or foveal contour. This is the first finding we should look for at on OCT or clinically, and also try to describe in the exams. And it can be again focal or broad base associated with some other form of pathologies like epiretinal membrane or cystic or degenerative changes in the retina. Over a period of time, there is a group in last 7-8 years called as Whisper, which has changed the way we used to think about these disorders. They also told us to look about the vitreous width, how much it is attached, what are the interface features, how is the shape of the fovea, what's happening to the retinal pigment epithelium, elevation of the vitreous attachment, and inner and outer retinal changes. So if you look at the classification given by Whisper, which is available in their article, you can go through it carefully, but we like to see three things very majorly: the vitreomacular adhesion or traction, which is causing the inner retinal changes, the changes in the outer retinal architecture, and also changes at the level of the epiretinal membrane, signifying and further classifying as how far or how severe is the traction, grading them accordingly, and then trying to plan the management for our valuable patients. So the management changes based on these scenarios, which takes care into account all these considerations. Then comes the next important thing is something called as epiretinal membrane or ERM, which further has been graded into 4 grades. Stage 1 is very thin nascent in ERM with a good vision. Then you have a slight distortion of the inner retinal architecture, which a slight drop in vision, stage 2 ERM. Then you have a stage 3 ERM, further distorting the inner as well as the outer retinal architecture, but still the RP photoreceptor layer is intact. Then you have the stage 4 ERM, where there is absence of foveal pit, disruption of the retinal layers, and presence of ectopic inner foveal layers. So this is called as ectopic foveal inner layers, or EFIL. Ectopic inner foveal layer, that is stage 4 ERM, presents a poorer visual prognosis. Sometimes you can even have tractional abnormalities, which are called as central bouquet in ERM, in which you need to look at the cotton bulb sign right at the level of photoreceptor layer, or foveolar detachment, which can again prognosticate a poor sign, or vitelliform type of a deposit can also confuse clinically when you see this kind of picture, whether we are dealing with vitelliform lesion or a ERM. But these deposits can happen over a period of time, signifying slightly poor prognostic factors. So all these things, if a OCT printout has to be given to you, if you look into all these things, the examiner can be very, very impressed. Then coming to the macular hole, first let's see what are the types of macular hole apart from idiopathic macular holes. Okay, so let me simplify. What are the types of macular hole apart from idiopathic macular hole? One can be degenerative, where the retinal layers are showing changes of the degeneration. The other will be tractional, where you have a separation on the horizontal plane, where you see definite traction in form of epiretinal membrane or taut posterior highlight, which is trying to pull the retina. So in simpler terms, this can be called as a top hat classification, or it can be a mustache type of a classification. So once you classify a macular hole, especially lamellar macular hole, in degenerative to tractional variety, then you go and you ask yourself whether there are any associated factors or associated features. There are many. I have just taken 2. One is called as LHEP, that is lamellar hole associated proliferation. This again indicates a poor prognosis, where there is no clear separation of retinal layers here, difficult to peel the membranes, or there is a perimacular membrane, which is easier to peel as compared to LHEP and gives a slightly better prognosis for the surgery. Then you come to the idiopathic macular hole. Now this is from the gas era, where there was no OCTs. On the histopathological slides, he classified macular holes starting from stage 0 to stage 1, 2, 3, 4, 5, which still holds true as the, the stages progresses. The separation of the retinal layers increases and the hole size keeps increasing along with secondary changes in the retina, mostly in form of a cystic changes. Sometimes you have also atrophy of the outer retinal layers. So this is the way it has been classified. And if you see the recent classification given by the Whisper Society or Tractional Study Group, also has been on the similar lines, where stage 0 is like you don't see any changes in the inner retinal layers, or the inner retinal layers are still intact. There's just a traction. That is called a stage 0. Then stage 0 progresses to stage 1A, which can be in form of vitromacular traction. Then vitromacular traction can be further classified with stage 1A or 1B, depending on the cyst or the separation of the vitreous cortex. Then you have a different form of lamellar macular holes going all the way to progressively to full thickness macular hole. So this is all OCT based classification recently, which gains importance because it is easy to do, the test is easy to perform and easy to diagnose. So this is all classifications as small holes can be less than 250 microns on the minimum width. Then you have medium holes, which can be 250 to 400 microns. And you have a large macular holes, which can be more than 400 microns on the minimal diameter, which is available, or minimal width. When we talk about macular hole, we always talk about macular hole indices. The common questions or favorite questions of examiners, as they will ask you, how will you prognostic your patient that macular hole is going to close after the surgery. So there are many of these. Just remember two. One is something called hole form factor, and one is called as macular hole index. This is nothing but the measurement of different separation layers of the retina, with the minimal base diameter to the maximum base diameter to what is happening on the height, and calculating it and just giving a prognosis to our patients. So if you have a hole form factor which is more than 0.9, it has a good prognosis, and macular hole index which has more than 0.5, it has a good prognosis. So if you remember these two or learn these two, this is more than enough for your exams. Then macular hole surgeries, this patient underwent surgery, has something called as a type 2 closure. That means you don't get an intact foveal layers or U-shaped foveal contour, which can be maintained. If it is a V-shaped contour, it is type 2 closure. If you achieve a U-shaped contour, which looks anatomically as normal as possible, then it is called as a type 1 closure. And sometimes you even have a non-closure, and there are different causes for non-closure of macular holes. Last but not the least, we have something called as a traumatic macular hole. Just remember, in exams, most commonly these cases are not kept. But whenever you have something called as a not fitting into the idiopathic type of a hole factor variety, and you see something like this, where the separation is more on the base and the retinal layers are incontiguous. So you have something called as a traumatic macular hole. The treatment for this is definitely observation for minimum 4 to 6 months. Then only you offer surgery for these patients. Let's look at a couple of real world scenarios. I'll quickly run through a couple of videos. This was a patient who needed a surgery for macular hole. As you can see here, this was about 12 to 15 years back. We operated large basal diameter. We used to peel ILM like this quite vigorously in this patient, and ultimately giving a good anatomical and functional closure. But what you see here is we have still not achieved a type 1 closure. It's still on the variety of type 2 closure. Just for a couple of things which have changed over a period of time as well. We operate this kind of a large macular hole. Sometimes the ILM flap, you just lose out. But over a period of time, you learn how to master the technique and try to close this kind of a macular hole. The third thing is the recent advances. Sometimes they can ask, the amniotic membrane is one of the favorites, which can be used to close this kind of a large macular holes or failed macular holes. In this case, we use amniotic membrane graft. Though functionally the vision didn't improve much, but you achieve a good anatomical closure at the end of the surgery. All right. So these are a couple of recent advances. We also have something called as a retinal autograph. In the interest of time, I have not taken in that things into consideration. Couple of other things where you have the vitromacular traction. The surgeries have changed in recent times. These are a couple of recent surgeries which I'm showing here. As you can see here, with the cutter as a single instrument, you can peel, you can lift the membrane, and you can, take your entire traction area, what is required to peel for this particular case. And this is a real-time unedited video. In a couple of minutes, you can finish off the surgery and get a good anatomical and functional closure for these patients with just air as a tamponade. Case where you have a epiretinal membrane like this, clear-cut indication for surgery. Again, just as a cutter, as a versatile instrument, you can, pick and choose your patients and do the entire surgery with just one single instrument. Sometimes stain can use, sometimes the stain is not required. And these are all 27 gauge vitrectomy eras where you get a lot of precision, lot of control while peeling this membrane. And the control is much superior, much better as compared to the conventional peel. And these kind of cases can be done about in 15 to 20 minutes time with good anatomical and functional outcome. So a lot of advantages over a period of time, the way macular hole or vitrectomy, vitreomacular traction surgery, vitrectomies have changed, giving us a lot of advantages. Sometimes you have to combine with either vitreous hemorrhage or tractional retinal detachments and so on. So just to summarize, in the interest of time, the management of macular holes have come a long way. Surgical management is the way to go apart from observation in select cases. Corrective investigative modalities have to be utilized as and when required, especially OCT-based diagnosis. Vitrectomy with internal limiting membrane flap creation is the standard of care for macular holes, whether it is on the lamellar hole side or the full thickness macular hole side as of now. However, these approaches are very individual, very specific for the patient's anatomy at presentation and as well as the surgeon's comfort. Patient's needs and expectations also needs to be assessed correctly before advising any kind of surgical procedures for this patient, because they can also have a downhill if the surgery is not gone correctly. An optimal anatomical and functional outcome should be assessed and provided to our valuable patients. Thank you so very much for the opportunity and as well as for patient hearing.
Thank you so much. Thank you so much, Dr.
Thank you,
Manoj.
sir.
Nicely summarized. And so a cataract patient coming to the OPD, you have to carefully assess the macula, not to miss these macular findings. VMT PGs should know how to recognize it, the epiretinal membranes, of course, macular hole you can see, and which are the poor prognostic cases, where the big hole, the old holes with atrophy. And yes, and you should also know about a little about the gases which we use, the C3F8 or the SF6, and the prone positioning. And of course, the time is reduced now, and some people do not use much of it now. And that is it, I think. Thank you so much, Dr. Manoj.
Thank you, sir. Thank you.
So just one little thing to add to this. Nowadays, in fact, the examiners might also want to hear in certain institute that there is a new thing that you can close the macular hole in air also. So this is something which is new coming up, and sometimes they might ask this.
These cases have been closed in air only nowadays.
Yeah.
Most cases are being closed in air unless and until you need long-term tamponade in select cases.
Yes, sir. Yes, sir. That is why. Thank you, sir. Sir,
Thank you. I think Ankur, I got little late. Thank you, Manoj sir, for taking this important lecture. Abhi, Ankur, can I know how many talks we are left with?
So we are halfway done. We are done with 9. We are going on 10th.
Then okay, chalo, go ahead. So you are planning till 10 p.m. today?
So
Chalo, ठीक है. देखो, I think this is how we learn. This is how we become more wise students. So let's take a marathon retina session today.
Okay.
I'll be here. Don't worry.
Yeah. So we go on to the next talk. Next talk is very important because we are going to discuss retinal detachment, and this is something that every postgraduate should know for examination. And for this, Dr. Aditi is joining us for the topic. Over to you, ma'am.
Are you able to see my screen?
Yeah. Yes, ma'am.
Yeah. Thank you, Dr. Ankur, for the introduction, and thank you, Dr. Praful sir, for the opportunity. I'll be talking about retinal detachment types and workup. So this is just my notes of very crisp points on which the PGs can build for the theory and some practical points for the practicals as well. What is retinal detachment? It is separation of neurosensory retina from the RPE. Now, looking at types, it's either rhegmatogenous retinal detachment, tractional retinal detachment, or exudative retinal detachment. In the subsequent slides, I'll be comparing all three. Firstly, let's understand what each is. So, rhegmatogenous retinal detachment is secondary to a full thickness retinal break, where the liquefied vitreous enters the break, goes subretinal, and that's how you have the detachment. So, an image here showing the same. There's a break here, and a detachment here, which is marked, and that's a rhegma and a detachment right there. Secondly, what is a tractional retinal detachment? Again, it's the separation of neurosensory retina from the underlying RPE. However, here it is due to traction resulting from the membranes in the vitreous or over the retinal surface. This is an image showing the same. You have these membranes that are formed here that pulls up the retina, causing a detachment. This is a case of diabetic TRD, though. The spots on the right here are old laser scars. The third type that I mentioned is exudative retinal detachment. Again, this is where the fluid accumulates in the subretinal space that is secondary to either inflammation, infectious, or neoplastic disease of the choroid and retina. There's an image here showing the same. Let me zoom this for you. You can see a small pockets of bullous fluid here, here, also here. Let us now have a comparison, all three on various subheadings. Pathogenesis reiterates what I just said. In a reg RD, you will have a retinal break, liquefied vitreous that passes through it and causes the detachment. In a tractional retinal detachment, you have proliferative membranes that contract and elevate the retina. In an exudative RD, you have subretinal exudation, which is secondary to infective, inflammatory, or neoplastic disease of retina and uvea. Moving on, history-wise, I've not elaborated the entire list of causes, but some important factors here. In Reg RD, there are some history that is important while you present a case or when you write the theory. That is, they typically may have preceding photopsia and floaters. History-wise, it's important the refractive error, a family history of RD, lens status, aphakia or pseudophakia, blunt trauma. In TRD, most common being diabetes, vascular diseases, sickle cell retinopathy, branch retinal vein occlusion, and ERD, as I mentioned earlier, uveitis, malignancy, or infectious diseases. Of course, there's a more elaborate list that one can further read on. Moving on to fundus findings, let us take each of this. Reg RD, you can see an RD right there. Let me just label this. So the most important thing firstly is over here, Schaffer's sign. In a fresh RD, you see something called as tobacco dusting in the anterior vitreous face. That tells us that the RD is a fresh RD. Then moving on to the fundus findings, we can see that there is an RD and it's describe it in terms of clock hours or the extent of RD. Reg RDs are typically these undulating, which means wave-like bullae, the folds that you see here. There is a large horseshoe tear here, and that is the underlying RPE. The other things that becomes important in mentioning or describing a reg RD becomes the state of the macula, whether it is involved or not. Then posterior vitreous detachment, very important, and proliferative vitreoretinopathy, as each of these factors help us decide the management and also prognosticate the case. Moving on to link-off rule, a very frequently asked question in postgraduate exams. Now, this helps us locate a break in an RD. So these are the 6 diagrams. The blue on the of the retina is the detached part and the red is the attached part. I'll just quickly go through these. The first one, if there is a shallow inferior RD in which SRF is slightly higher on the temporal side, then a primary retinal break would be located inferior on that side. The second picture shows us that there's inferior RD with equal SRF on both sides. And in this case, the break would be at 6 o'clock, right here as depicted. The third diagram, a bullous inferior reg RD. A primary break would usually exist above the horizontal meridian as shown here. The fourth one is a diffuse regardie with superior wedge shaped attached retina. Look for break on the on the side which is higher, closer to the oda. Fifthly, a subtotal RD with a smaller superior wedge attached. A primary break would be in the periphery nearest to its highest border. And lastly, when there is a diffuse reg RD with an inferior attached wedge-shaped retina from, we can look for a break at closer to 12 superiorly. So this becomes important in practicals and also in theory for postgraduate exams. Moving on, now we are done with the reg RD fundus finding. Let us look at the TRD fundus finding. That it can be varied in appearance. The main thing to understand here is, if you look at this fundus diagram particularly, you will see all these membranes that are attached all over at the posterior pole. And these contract, they are fibrovascular membranes. So the contractile element in it peaks and contracts and peaks the retina and pulls it up. Moving on to exudative RD, the same picture. Now, they can be central or peripheral. They're very smooth bullae. They don't have folds like the reg RD. If you can see, it's the same picture that I showed earlier. So these are several bullous detachments. They are smooth compared to the reg RD. Moving on, if one looks at the ocular coherence tomography of each of this, in a reg RD, you can see a clear-cut elevation of the neurosensory retina from the RP right here. RP here is the brightest band, and this is the retina lifting up. The second one, in a TRD, you can see all these membranes attached to the retina and pulling it up, and that's when you have this detachment here. The third case is actually of a VKH case, and the bullae you can see as loculated areas like this, which lifts the retina. And they are more smoothened out and loculated. The next modality would be a B scan. Let's compare again all three head to head. Here you will see like a wave-like pattern again, a membrane in the vitreous cavity, highly reflective with a higher spike and good mobility. In a tractional retinal detachment, you have these concave borders. That's because of the taut retina, because of the membranes pulling it. You can see it right here. And if you look at exudative detachment, you can have various kinds. Typically, they are dome-shaped elevations, more smoother, and one can elicit a shifting fluid. And now, how does one do that? You check for the scan in sitting position, make the patient lie down for 5 to 10 minutes and do the scan again, and you can see that the fluid has shifted and the configuration of this dome shape has changed. Very important question that typically examiners ask, little bit deviating from here, is reg RD versus retinoschisis. We already saw the reg RD component part of it. In retinoschisis, it's actually the split in the retinal layers. So on a B scan, to distinguish between the two, you will see a thinner membrane, mostly dome-shaped, does not move, and the spikes are much lesser, and their typical location in the inferior temporal quadrant. Another common question, because I was talking about B scan, that commonly gets asked is differentiating between reg RD and choroidal detachments. Now, choroidal detachments are typically peripheral. They do not come to the center, of course, are limited by the vortex veins. You will have an M-like spike typically seen around it. They are thicker bands and they are immobile, compared to an RD. These are few points to differentiate the B scan between the two. Looking at practical aspects of this, we have, in practicals in your case presentations, what is important is to understand the positive history or all the risk factors that we understood. IOP is important because sometimes a reg RD may show lesser IOP. Refractive error, as myopes are commonly affected. Gonioscopy becomes important in cases like TRDs and advanced PDR, where you have, if the anterior segment is affected in case of, let's say, neovascular glaucoma and such. Lens status, because again, phakics are more prone. Pseudophakics with the PCR or posterior capsular rent are more prone. And then one must mention the fundus findings and the drawings on an Amsler-Dubois chart. And always mention a complete diagnosis. So let me take you through a case example of a 33-year-old man who comes with sudden onset blurring in the right eye for 4 days. Now, the vision in that eye is counting fingers close to face. The IOP is slightly lesser, about 8 millimeters of mercury. It's a very high myope with a diopter of, minus 22 diopter spherical. And this is how the fundus looks like. You see an RD here, several small HSTs around. That's a bullous looking RD, undulating, as I explained earlier. And there's also superior retinal hole. And of course, involving the macula. And this is a chart which gets, in practicals, you must mention it. That's how you depict it. The same diagram, the retinal hole, the HSTs on the side, attached retinas, of course, red, and detached retinas, of course, blue. The green ring over here depicts the PVD, that's the V's ring. And there is also a lattice inferiorly, which is depicted here. So, and mention a complete diagnosis like reg RD, macula, whether it is involved or not, the status of the lens, and of course, pathological myopia. So the frequently asked question in these kind of cases are Linkoff's rule, which we already looked at, to differentiate between reg RD, tractional RD, and exudative RD, which we just went through. And very commonly in practicals, if you get one of these cases, they ask the basics of IDO, indirect ophthalmoscopy, the lenses used. So you must know about them. Then B-scan, which we discussed. Of course, they also ask about scleral depressors, because the gold standard, of course, is to do a 20 plus 20D diopter dilated retinal examination with scleral depressors. So the type of depressors used, whether it is thimble, Shockett, so they also keep it for table viva. And Amsler-Dubois chart, which I had shown earlier along with the case examples. So these are few points to understand the types of retinal detachment and how to work up the case. And of course, the management part will be subsequently discussed. Thank you.
Thank you, Aditi. That was a wonderful talk. This Amsler-Dubois chart, students, no matter how much you know retina, but if you do it wrongly, then you are failed, I think, right, Dr. Ankur?
Yes, ma'am. Yes, sir.
A very important topic. Let's move on to the next talk, Dr. Ankur.
Yeah. So for the next talk, that is on the management of retinal detachment, I would like to invite Dr. Aarti Mohan Kumar. You are here, ma'am. Dr. Aarti
Yes,
Mohan.
Dr. Aarti is there. So
Yeah.
RD is a very important case. So that's why we have divided into two sections. Workup is important. Now the management part. Yes, Dr. Aarti.
Dr. Aarti is a consultant via Sajan Rajan Eye Care Hospital, Chennai. Over to you, Dr. Aarti, ma'am.
Good evening, sir. I hope my slides are visible and I'm audible.
Yes, yes. Go
So,
ahead.
without much further ado, I'd like to go ahead with the talk with the beautiful context set by my previous speaker, Dr. Aditi. So, I'll be sticking to the management of retinal detachment. So, as Madam has beautifully summarized, retinal detachment is classified into all these types. So, whatever the type of detachment is, the principle of managing these cases is to ensure the retinal reattachment. So the retina has to be pushed back to its original position. So depending upon the type, the rhegmatogenous and tractional retinal detachment are managed surgically, whereas medical management is the predominant way of managing an exudative retinal detachment, except in select cases. So we'll briefly see an overview of how each type of detachment is managed. First, going on to rhegmatogenous retinal detachment, first I would like to start by emphasizing the role of barrage laser, where a localized retinal detachment, which is not extending up to the fovea, or which is not extending more than 2 clock hours, which is defined as a subclinical retinal detachment, can be safely treated using a barrage laser. Next, coming to pneumatic retinopexy. So, pneumatic retinopexy is done in patients with a single superior break or multiple breaks, which are seen above the horizontal meridian. So, the patients should not have much of PVR changes or other coexisting pathologies like a vitreous hemorrhage or a macular hole. So, the commonly used agents, which is commonly asked in the exam for pneumatic retinopexy, is what are the agents used for this or the gases? So, air, SF SF6 and C3F8 are used, and the decision to choose each of these agents depends upon the duration of tamponade you would like to have. So this table is a very important table which you should remember. I hope all postgraduates will be familiar with this table. So AIR offers the shortest duration of tamponade, whereas C3F8 offers the longest duration, which lasts up to 8 weeks. So contraindication is when there is an inferior detachment, or the brakes are in the inferior quadrant, because gas does not tamponade the inferior brakes well. And when there is a hazy media, when you cannot localize and achieve retinopexy or well, so it is generally contraindicated. One significant thing you will have to inform the patient is that they cannot travel by air, because higher altitude will cause expansion of the air bubble, sudden raise in IOP, acute pain, and may even result in central retinal artery occlusion. So for pneumatic retinopexy, an expansile volume of the air is used in a non-vitrectomized eye, which is 20% for SF6 and 14% generally for C3F8. And 0.3 to 0.5 ml is injected, and the air bubble is allowed to expand into the eye, while the patient maintains a required position. It may be prone, it may be left lateral, or it may be right lateral, depending upon the position of the brake. And after which we follow up the patient and do a laser to maintain the chorioretinal adhesion. This is especially useful in patients who are cooperative and are able to maintain a position, whereas the same comes as a disadvantage, and it cannot be used in elderly and uncooperative patients who will not be able to maintain a positioning. The duration of this positioning will be for the duration of the tamponade, because once the effect of gas bubble goes off, then the positioning is not going to make any sense. So again, complications are very important, and they are asked, which include raised intraocular pressure, formation, induction of PVD, and formation of new brakes, for which we should be constantly monitoring the patient. Also, it can result in increased IOP. It can migrate into the subretinal space. It can also result in cataract formation in a phakic patient. Now coming to scleral buckling. So now it is the era of MIVS, which is microincision vitrectomy surgery for management of retinal detachment, but scleral buckling still has a role to play in the management of rhegmatogenous retinal detachments. Here, the principle of surgery is to identify all the brakes, achieve adhesion of the brakes either using LIO, which is laser retinopexy, or using cryo, and then using an implant like a scleral buckle or a sponge to support the brake and maintain the chorioretinal adhesion. So the indications include fresh RDs with almost no PVR, and in young phakic patients in whom PVD may be difficult to achieve, and vitrectomy may result in damage to the lens. So it is especially not useful when there is extensive PVR. It is associated with other pathologies like macular hole or a dense vitreous hemorrhage, which will need vitrectomy. So again, the choice of implant I've just mentioned briefly, whereas there are various implants of various sizes available. So it can be circumferential or segmental, which depends upon the number of breaks which are present in the patient. So the steps of surgery of scleral buckle, which I'll go through briefly, it includes giving an anesthesia, which can be either general or local peribulbar anesthesia. After 360-degree conjunctival peritomy, we isolate the recti muscles. We localize the brake using indirect ophthalmoscopy, mark the brake externally, and then achieve adhesion of the brake either using cryotherapy, which is commonly used, and then we place an encircling band. The band is sutured to the sclera using a 5 or 6-0 non-absorbable suture. So there are two techniques, where there is a drainage and a non-drainage technique. Both can be performed, after which the buccal height is adjusted, and which is followed by closure of the conjunctiva. So of course, the advantages are a high success rate. There is no damage to the internal structures, no need for positioning, which is very annoying to the patient. And there is no other vitrectomy related complications. Whereas the disadvantages include diplopia, causing a refractive error, missed breaks, which can result in retinal detachment, perforation of the sclera, which results in submacular hemorrhage, so subretinal hemorrhage, and sometimes causing a very tight band may interfere with the central retinal artery perfusion, and it may result in a CRAO. So periodic indirect ophthalmoscopy examinations during the procedure, looking for CRA pulsations and doing a periodic AC tap is mandatory, which is the most crucial point in performing these surgeries. Next, coming to the pars plana vitrectomy, which is the most preferred and sought out procedure these days, considering the advantages and the different advancements in the technique. So it can virtually be used for all types of retinal detachments. But the choice of procedure comes with pros and cons in patients. So here I'm going to use a short video. This surgery is by a very good friend to describe the steps of retinal detachment, which starts with achieving 3 ports, after which core vitrectomy is done. In this patient, macular hole is noted. Once the vitrectomy is complete, the SRF is drained internally, in contrast to the scleral buckling procedure where external fluid drainage is done. In vitrectomy, the procedure is drained internally. So here, a thorough removal of the vitreous is achieved by doing a core vitrectomy, PVD induction, followed by base dissection as shown. Here, since this patient has a macular hole, the ILM is being stained using BBG, and then peeling of the ILM is done to ensure the hole closure. After this, PFCL is used to drain, and the fluid exchange is done. PFCL is used to flatten and stabilize the retina, following which superior draining retinotomy is made, and the retina is settled. Once it is settled, endolaser is done and silicone oil is injected with very good results. So the advantages is nowadays surgeons are trained to do this procedure, so better outcomes, better visualization with wide angle systems, not much of refractive shift, useful in complex detachments. Whereas the disadvantages include again detachments, hemorrhages, risk of endophthalmitis, accelerates cataract formation. Again, the use of tamponade needs positioning in the patient, and it comes with a higher cost. So the frequently asked questions in this scenario may be the examiner may ask you to list out the treatment option and where each procedure can be used to its advantage. So this table just lists the procedures out. So generally, inferior detachments, you need either scleral buckling or pars plana vitrectomy with the oil tamponade. Superior detachments do well with the gas tamponade. Now, quickly going on to tractional retinal detachment, as the previously madam described, here the cause of retinal detachment is the formation of pre-retinal membranes which contract and pull the retina. So principle of surgery here is to eliminate the traction and ensure adhesion. So indication of surgery is macula threatening or macula involving TRD which is progressing, TRD which due to the traction develops a regma and progresses into a combined mechanism RD, and non-resolving vitreous hemorrhage. A stable extrafoveal or a nasal TRD which is not progressing can be safely observed. So when treating patients with TRD, I would like to emphasize the role of control of diabetes, because we might be operating and without systemic optimization, we will not achieve good results. Here again, another question may be asked, which is very important, which is the role of anti-VEGF in the management of TRD, where typically anti-VEGF is given 3 to 5 days before the procedure. The purpose of giving a preoperative anti-VEGF is to cause the regression of the vascular component, so that when we touch and deal with the membranes, there is not much of a bleeding. But the risk is, if you do not operate within the time period, the contraction of the vascular component results in the worsening of traction and worsening of the retinal detachment, which is described as a crunch phenomenon. So again, this technique of membrane peeling, which is also a pet question, where segmentation, delamination, and en bloc dissection. Segmentation is where a broad membrane is cut into small pieces. Delamination is when the membrane is separated from the retina. En bloc dissection is when you remove the membrane in total without performing the other 2 maneuvers. So here I would also to explain the steps of surgery. So after making the sclerotomy, so we are making doing anterior vitrectomy, and here this is called as the truncation of the cone or the core vitrectomy, where the adherent hyaloid is around the membranes is cut and segmented. So following which we are go on to address the membranes, where you can see the membranes are separated from the retinal surface, and you can see some bleeding is occurring while the membranes are being handling. So this is where anti-VEGF helps, where it helps to control the membranes. So here you can see the surgeon is peeling off the membranes from the retinal surface. So I'm just skipping for the want of time. So once the membranes are dissected and removed, you can see fluid air exchange is done, and then endolaser is done, and the case is completed with the silicone oil tamponade. So here again, while performing this surgery and while performing the membrane dissection, we should be careful as to not form new breaks. And if we form new breaks occur, which are called as iatrogenic breaks, we mark them using endocautery and we seal them so that it does not lead to a redetachment in the postoperative period. So next, coming to exudative retinal detachment, as Madam has described, it is classified into neoplastic, vascular, or a systemic and inflammatory. Treatment of exudative retinal detachment is mainly by treating the cause. Surgery is indicated only in rare scenarios where medical treatment has failed and you need to drain the fluid, or there is a secondary break or secondary traction developing, or for diagnostic purposes. So a short brief about the various instrumentation, because this may be asked in OSCE or in your table viva. So various vitrectomy machines, visualization systems for vitrectomy are contact and non-contact. Non-contact are usually wide angle up to 120 degree, and contact systems are usually a small field of view of around 90 degree, which are used for peeling the membranes. So these are the trocar cannula systems which are available in 23, 25 and 27 gauge. So this is the cutter which is used, the vitrectomy cutter. This is the light pipe which is used along with the vitrectomy cutter to illuminate the retina. So while doing a retina surgery, we do not depend upon the illumination of the microscope. We rather use the endo illuminator to visualize. So this is the laser probe. There are straight and bent laser probes. One question they may ask in the exam is why the bend in the laser probe? That is to suit the curvature of the lens to prevent the lens damage during laser. So this is another pet question, is the Charles flute needle, which is used to do a fluid air exchange or aspirate fluid, and it works by the difference between the pressure in the vitreous cavity and the atmospheric pressure. So these are various forceps which are used for peeling fine and thick membranes. I'm just skipping this for the want of time. So next, coming to a very important question, which is the adjuncts in vitrectomy. So various dyes like trypan blue, brilliant blue and indocyanine green are used to stain the membranes because they are transparent. Triamcinolone acetonide is mainly used to stain the vitreous. It is diluted triamcinolone, which is diluted up to 1:3 or 1:4 concentration. I just want to emphasize 3 points. Trypan blue stains the ERM. Brilliant blue stains the ILM. When you use both, it is called as double staining. When you use BBG to stain the ILM and the ERM doesn't stain, which gives again an edge, that is termed as negative staining. Indocyanine green though it offers good staining, it is associated with a lot of toxicity, so it's not used these days. So again, perfluorocarbon liquids is very fondly known as the third hand of the VR surgeon, is used to stabilize the retina, is used for specific indications like IOFB, for giant retinal tear, traumatic RD, management of suprachoroidal hemorrhage. It is a short-term tamponade which helps the surgeon intraoperatively. It should be removed completely. For complex detachments, it can be briefly left into the eye for 1 to 5 days, less than a week, after which the surgeons remove and proceed with the second surgery. So these are the various tamponades which are used at the end of vitrectomy. So the tamponades are chosen depending upon the duration of which you want it to be there. So the gases come with the advantage of not needing a second surgery to be removed, whereas oil needs a second surgery to be removed. And we have discussed the various scenarios where it has to be used. And again, the advantages and disadvantages and the indications of these may be asked in OSCE or in your table viva. So again, coming back to the initial slide slide I started my talk with. So the Reg RD, the main management is surgical. So it's either pneumatic retinopexy or scleral buckling or vitrectomy. Tractional RD is also exclusively surgical, whereas exudative RD is medical. Thank you for your kind attention. Thank you. And thanks for giving me this opportunity to speak on this topic. It's a very huge topic. I've tried to cover it within 10 minutes.
Very nicely
Thank you
done.
so much. Yeah, Dr. Ankur, please.
Yeah, sir, I just said she's covered it very nicely.
Yeah.
You can go ahead, sir.
Yeah, it's a very huge topic and very nicely covered. Thank you so much, Dr. Aarti. And PGs should know about the pneumatic retinopexy. What are the limited indications when to do it? And air travel is contraindicated after that. And scleral buckling, when to do it? An old-time examiner might ask about buckling, vitrectomies, of course, and so about silicone oil and gases you should know, and instrumentation. Yeah, we can have the next speaker.
For the next talk, we have the next talk is very important because that is on myopia and retinal degeneration. And myopia is something that we should all be aware of. For myopia and retinal degeneration, Dr. Purnbi will be joining us. He's a good friend from Narayan Netralu. He's a prolific retinal surgeon. Over to you, doctor.
Hi, good evening, everyone. Am I audible?
Yeah.
Hope my slides are seen in full screen mode. Hello?
Yes, Purna. Students
Okay,
is very
fine.
important topic, and he's master in this topic. So please listen to him carefully.
Thank you so much, Dr. Prafulla sir, for the opportunity and also the kind words. I know like so many of you are logged in. So I just wanted to tell one thing before I start the topic. See, now there is no dearth of information. You people can go to Google, chat GPT and all that. So the most important thing is, most of these things are volatile. Try and understand the concept so that you can retain it better. So don't try to mug up everything. Even if you read fourth time, you'll feel like you're reading it for the first time. To start with my topic, the retinal degenerations and myopia, first we need to understand the difference between a dystrophy and a degeneration. Because retinal dystrophies, we call dystrophies. Age-related macular degeneration, we call it a degeneration, not age-related macular dystrophy. The reason being, the dystrophies are inherited, non-inflammatory, early onset, bilateral, and symmetrical. Whereas degeneration can be sporadic, it could be late onset, can be unilateral. If it is bilateral, it will be usually asymmetrical. So that's the basic difference. So the dystrophies can be classified based on inheritance, the photoreceptor involved and all that. Based on inheritance, it could be autosomal dominant, where the one defective copy is enough to manifest the disease. In recessive disease, we need both the defective copies from the parents to be defective to manifest the disease. X-linked dominant is also like an autosomal dominant. Coming to the X-linked recessive, this also acts like an autosomal recessive disease, but only difference which you need to remember is since males have only one X chromosome, they tend to manifest the disease. The females, they have two X chromosomes, they become carrier unless they carry two defective genes. Fine. So this is one of the commonly asked questions in this thing. What's the definition of a retinal dystrophies? So these are nothing but, as I already covered in the differences, a group of heritable disorders with ophthalmoscopically visible abnormalities, secondary to premature retinal cell aging and also a cell death, which are bilateral, and these are inherited in Mendelian fashion. So that's most important. Again, dystrophies, as I told, can be classified in different ways, like dystrophies affecting the peripheral retina, dystrophies affecting the macula, and based on the photoreceptor involved, like rod-driven dystrophies, cone dystrophies, rod cone dystrophies, and so on. So coming to the dystrophies which affect the peripheral retina to begin with, and later may progress to center. These includes retinitis pigmentosa, rod cone dystrophies, choroideremia, and the gyrate atrophy. Macular dystrophies, again, some can be dominant and some can be recessive. Don't try to mug up all these things. It's not easy to remember. So just remember the important ones like best macular dystrophy. Most of the time it's like dominant. Stargardt's is recessive. So there are other varieties like SOSP, dominant radial truncens, Narcarolina, the dominant. See, the name itself has the word dominant. So these are all comes under the dominant dystrophies. The most important, the recessive category is the Stargardt's because that is one of the commonest macular dystrophy. The commonest oral dystrophy is retinitis pigmentosa. Okay, that you need to remember. You should not get confused when they ask this question. Commonest retinal dystrophy is retinitis pigmentosa. Commonest macular dystrophy is Stargardt's disease. So before going to the case example, I'll just cover basics of fulfilled ERG. So this is recorded after 10 minutes of dark adapt, sorry, 20 minutes of dark adaptation. We call it as a dark adapted responses, which represent predominant rod-driven responses. So once we adopt the patient for light adaptation, that is for minimum of 10 minutes, what we get is a predominant cone system driven responses. So for a timing, we just remember that because I'll not go into the details of it because that can be a separate topic altogether. So now let's begin with the case example. Try and concentrate. I'll just try to cover many points which could be important both from the Viva point of view and also from the theory, and not only for the exams and also from the practice point of view. And I know some of you will be, attending interview for the VR fellowship, or some of you will be also, giving FRCS exam, and that also it is important. So this case presented with history of night vision and also history suggestive of tunnel vision. If you look at the central vision, so it was quite okay. It was 6, 9, and 6. And this is the fundus picture. Okay, so there's no prize for guessing. All of you know it. This is a classic case of retinitis pigmentosa. So again, what's the commonest question asked? What is the triad of retinitis pigmentosa? If you see, one is the waxy pallor of the disc, vastly attenuated vessels, and bony spicule-like pigmentation. This is a triad of retinitis pigmentosa. So this is the OCT of the retinitis pigmentosa. If you carefully observe, the ellipsoid zone is present only in the foveal region. That is the reason why they have tunnel vision. Okay, because peripheral retina is degenerated and the photoreceptors are surviving only in the foveal region. If you do an ERG in this test patient, what will happen? Look at the dark adapted responses, undetectable, undetectable. Same with the light adapted responses, it's an undetectable, it's a flat line. And the same in the left eye also. Why? The reason being, the photoreceptors which are present only in the foveal region are not enough to elicit a fulfilled ERG response. So if you see a classic RP patient, then no need to do an fulfilled ERG. If at all, if you want to study the functional aspects of it, you can go for multifocal or pattern ERG. And there are other variants of retinitis pigmentosa. These are called the RP sign pigmento, in which it will have all the features of RP except for the bone spicule-like pigmentation, as you can see in this picture. And one more is retinitis punctata albicans, where you can see this multiple white dot lesions in the mid periphery. And this is very important. I have been the coordinator for both DNB and FRCS. They will give you the OCT and they will ask you to interpret this. And you should not just comment on the foveal contour normal and you should not conclude it's normal. If you carefully look at the outer retina, the ellipsoid zone is present only in the foveal region. Compare this to a normal OCT. This is how a outer retina should be. The ellipsoid zone layers and other layers should be continuous. Here, if you observe, it's present only in the foveal region, as I was describing in the previous slide. So this is something we should never miss. So this is sometimes could be a tricky question. Fine. So coming on to the second case, this was a 11-year-old male presented with blurred vision, and the vision was around 6'9", and he had a history of consanguineous marriage in the parents. If you look at the fundus photo, if you just concentrate on the macula, there is a yellowish deposit in the macula, which gets better appreciated once you do the autofluorescence. So this is nothing but a vitally formed deposit. Okay. And if you look at the corresponding OCT, there is subretinal fluid along with these deposits. And when you do an ERG for this patient, the fulfilled ERG is absolutely normal. The EOG is completely abnormal. In EOG, there should have been a light peak like this, which is not present. So whenever you get a case like this with vitaliform deposit in macula with a normal fulfilled ERG and an abnormal EOG, you are sure that we are dealing with the case of best macular dystrophy. And it's very important to screen the family members. If you look here, so this is the father who was totally asymptomatic, but when he screened him, so he had a very subtle foveal vitaliform deposit only in the left eye. The disease manifestation could be as subtle like this. So it's extremely important to screen the family members once you diagnose any patient with inherited retinal dystrophies. Of course, when you did a genetic testing, we already know the BEST is a dominant disease. So we had a heterozygous mutation in BEST1 gene, indicating a dominant inheritance pattern. So best macular dystrophy is one of the common Mendelian macular dystrophy. The characteristic lesion include a vitaliform or egg yolk-like appearance. One more Viva question or an MCQ question. Egg yolk-like appearance is seen in so and so, and it can go through various stages. You people can take a screenshot and keep it. I'll not go into this. That's vitaliform, pseudo-hyperpia, and vital eruptive. So basically, all this stage corresponds to a different stage in which the vitaliform deposit is getting absorbed. So most of these patients maintain a vision of 20/20 or better, unless it is complicated by a secondary choroidal neovascular membrane formation or fibrotic changes. And most of these patients tend to have hypermetropia and narrow angles, and you need to do a gonioscopy, and if present, you need to do a ERPI, so to relieve them of the angle closure attacks. Fine. I'll just show one more case which is related to the best macular dystrophy, but it's a different one. If you look at the vitaliform deposit as compared to the first case, which was limited to the macula, in this case, it's quite extensive even outside the arcade also. If you look at the OCT, the first case had only the subretinal fluid. This case has subretinal and also intraretinal fluid. This is autosomal recessive bestrophinopathy. So basically, this is also related to the bestrophin gene. The first one which I showed was a dominant best. This is a recessive. In the first patient, only one copy of the gene was defective. In this patient, both the copies are defective. That's why the disease is little aggressive. That's the general reason for why recessive diseases are little aggressive as compared to the dominant ones. Fine. So going on to the last two category of cases. This was a 26-year-old female presented with blurred vision with a vision of 6/60. If you look at the macula, it was completely atrophic. So again, she was born out of a consanguineous marriage, and it's very important to draw a pedigree charting once you diagnose any patient with inherited retinal dystrophies. Whatever the atrophic changes which I told you in the macula, which was better appreciated once you do an autofluorescence test, you can see in addition to the atrophic macula, there are multiple whitish flex-like deposits, and OCT shows foveal thinning with outer retinal loss. So all of you know that diagnosis by this time. This is a classic case of Stargardt disease. So let's see what happens once you do an ERG in these patients. And if you just, whenever they give you an ERG, for interpretation or for diagnosis, please don't jump into the diagnosis. Just try and describe. Just if you look at the dark adapted responses, this blue line belongs to the normal, the black belongs to the patient. So the B wave was supposed to start here, but it's starting here. So the latency delayed, and the amplitude was supposed to be like this, but there is a gross decrease in the amplitude. And the same thing is seen in the combined responses also. If you look at the light adapted responses, it's the same story. The peak which was supposed to start here, it's starting here, and the amplitude is almost even says more than 70% decrease in the amplitude. So what does this indicate? Basically, it indicates both the cone component and the rod component. Both the cone and rod systems are affected. That means there's a cone rod dysfunction. The term which you need to use is dysfunction, not dystrophy. Okay, clear? So this could be anything. Okay. So in this case, in Stargardt's, though we knew the diagnosis, why did we do the ERG? Because our patient belongs to a type 3 Stargardt, because based on the ERG, the Stargardt can be of three types. In type 1, the fulfilled ERG is normal, less chance of progression. In type 2, only cones are affected. It's a 20% chance of progression. Whereas in type 3, in our case, with both cones and rod systems are affected, there is a 80% chance of progression. In this way, you can also, prognosticate patients with retinal dystrophy, because that's the next question what patient is going to ask once you diagnose the dystrophies. So this patient has expected ag mutation in ABCA4 gene, and these are again some of the viva points. The fundus appearance in some forms of targets, it could be normal, or there could be an early foveal atrophy, or you can see a beaten bronze appearance. Okay. So in the macula, and sometimes you can also see yellow white flakes, and sometimes they can also have bullseye configuration. Yeah. So flex, beaten bronze appearance, bullseye configuration, all this can be seen in Stargardt dystrophies. Yeah. Right. So the management includes, currently there is no treatment. There are multiple gene therapy and drug trials which are underway. You can give them low vision aids, and also most important to give them the dark glasses to avoid bright light. And the most important thing in Stargardt's is please avoid giving vitamin A or any aided supplementation to reduce the bisretinoid formation, which can further lead to degeneration. Fine. So this is the last case. The 22-year-old male, he presented with a blurred vision, with a vision of 6 by 36 and N18. He had history of a photophobia, but fundus clinically looked absolutely normal. And if you look at the autofluorescence, very subtle changes in the fovea, whereas in OCT, you can see a clear-cut subfoveal cavitation, which resembles a photic retinopathy. But this is not that. I'll explain why. If you look at the ERG, the dark adapted responses are completely normal. If you look at the light adapted responses, it is undetectable. So that means the bone system in the patient's entire retina are non-functional. So this is a case of achromatopsia. Why am I calling it as achromatopsia, not cone dystrophy? Because cone dystrophies can be of two types: early onset and stationary, late onset and progressive. Our achromatopsia falls in early onset and stationary. That means the patient is born like that and is going to live like that. So it's not going to go blind. And when you tell this, patients will be very happy. So I'll just briefly rush through these juvenile X-linked retinoschisis. You can see the skytic changes which can be seen in macula and also periphery. One of the commonest finding which can be vitreous veins. These are nothing but unsupported blood vessels which will be in the vitreous cavity, and they can present with vitreous hemorrhage also. And the most important thing when it comes to juvenile retinoschisis is electronegative ERG. If you look at this combined response, the A wave is forming here. B wave, instead of going like this, it's getting terminated here itself. This is seen clearly in the maximal combined response. A wave is forming. B wave is not even reaching the baseline. So this is the classic electronegative ERG you see in juvenile retinoschisis. Basically, wherever there is inner retinal dysfunction, you get electronegative ERG, like congenital stationary night blindness, CRAO, ischemic CRVO, and also juvenile ischemic retinoschisis. Management, you can give topical dorsal and if there is a case hemorrhage or detachment, you can waive it. So to conclude, I would like to say dystrophies can mimic both inflammatory and pachychoroid group of disorders. A differential diagnosis is very important, and electrophysiological test can be a good adjunct, both for diagnosis and also for prognosis. And phenotype can vary in presentation, penetration, and also inheritance pattern. In case some of you are interested knowing more about inherited retinal dystrophy, AOS is, they're helpful to us in publishing this particular book. So you can go and read this. It will take just 3-4 hours. You can, cover most of the dystrophies in detail. Then myopia, I'll just take 1 more minute, just the salient features, because that was there in my topic. The fundus changes in myopia include the posterior staphyloma, the lacquer cracks, which are nothing but the breaks in the Bruch's membrane, and variable chorioretinal atrophy. And sometimes you can see these fugue spots. These are nothing but a pigmented scar, which is basically sometimes could be a telltale sign of a CNVM there. And also you can get a tilted disc, which is because of the axial elongation and oblique insertion of the disc. And also you can see chorioretinal atrophy here. So and there can be lattice degeneration. In early stage, the vascular sclerotic changes may not be that prominent. Then some stages, the sclerotic vessels in the base of the lattice can be prominent, and there can be sometimes associated pigmentation also in the lattice. One more variant is a snail track degeneration. Only difference is you don't see the sclerotic vessels in the base. Some people also say that this could be a precursor for a lattice. So basically, they all fall in the same spectrum. They can also sometimes see this white out pressure. There could be retinal breaks and holes. And when you do an OCT, so you can usually see a general retinal thickening unless this is skytic changes, as you can see this. And the most importantly, posterior bowing because of the staphylomas. And there could be areas of ellipsoid zone disruption, chorioretinal atrophy. There could be myopic maculopathy, so where there could be foveus crisis, which can be of three types: just the foveus crisis with detachment, and with associated macular hole. So myopic CNVM is something very important. So this is one group of disorder where CNVM can develop in young patients. Can be very obvious like this, as you can see in this OCT, or it can be as subtle like this. So it's extremely important to pick CNVM in myopia patient because they usually respond very well to the treatment. So and these are some of the Viva points when it comes to myopia. They usually ask why tilted disc, why glaucoma management is difficult in myopes because of all the disc associated changes, why early PVD, what are the RDCs factor, and so on. So thank you so much.
Thank you so much, Dr. Poona. It was a wonderful talk. So these would be the other conditions that the PGs might face in the Viva. So this book I have seen is very helpful, and PGs should go through it. And so the basic points they can take from this. Thank you so much.
Thank you, sir. Thank you.
So we can start with the next topic, Dr. Ankur.
Hello. Sir, let's go to our next talk. Next talk is very important. It's going to be on OCT and retinal diseases. And for this, we have Dr. Shashwati Mohan. Yeah,
Can you see my screen?
Yeah, yes. So Dr. Mohan is currently working in a Medcare Eye Center in Dubai, and she is also an education research associate remotely from Horizon Eye Care, Chennai. Over to you, ma'am. And this is going to be a very important talk for postgraduate. Kindly listen to it carefully. Thank you, ma'am.
Yeah, so today I'll be talking about OCT and retinal diseases, and I've been following the talks, and a lot of it has already been covered. But I'm just going to concentrate on the practical tips anyway that you need to know in your exam. So I'm just going to cover it in 10 tips. Let's start with tip 1, that is how to read an OCT printout. So in an OCT printout, when you're given this, especially in an exam, we first have to confirm the name, the age, what kind of scan was done, and the eye. And the important thing to look at is signal strength. The signal strength is graded 1 to 10, and at least a 6 signal strength is required, and less than 3 is poor and unreliable. So you have to mention this during the exam as well. And coming to tip 2, when you're talking about the OCT, divide it into segments. The first one will be the vitreoretinal interface. Second one will be the inner retina. Third one will be the outer retina. Fourth will be the RP Brooks membrane. And the fifth will be the choroid. Coming to tip 3, we need to know all the layers and the different terminologies. Of course, there are newer terminologies right now. And the important thing to remember, there are 10 layers in the retina, as everybody knows, but we need to focus on the important layers. And I'm sure the examiners will now concentrate on this. That is the ellipsoid zone, number 11. This is a hyperreflective layer, and a loss of this means a loss of photoreceptors. That means it indicates poor visual acuity. So we always have to look at ellipsoid zone, especially in chronic conditions such as DME, ARMD, etc. Because even if we keep treating, the vision may not improve because there's a loss of the ellipsoid zone. I'll give you a few examples later. Coming to tip 4, that is quantitative assessment. We always look at retinal thickness, that is the distance between the internal limiting membrane and the RPE, and the center point thickness, that is the average of the thickness for the intersection of the 6 radial points, and the central subfield mean thickness, that is the mean value of the 128 thickness scans of the circular area of 1 millimeter around the center point. So when we talk about an OCT, of course, the retinal thickness is very important, especially in abnormal OCTs and especially in case of macular edema. Tip 5 is qualitative assessment, that is normal reflectivities. So as you know, an OCT, especially in a grayscale, has either hyperreflective or hyporeflective bands. So this article, especially by Dr. Munna Bende et al., shows a very nice differentiation between the hyperreflective and the hyporeflective bands and zones. Important thing to remember and a pearl that when you're looking at this immediately in an exam and trying to comment on it, remember that plexiform are hyper. So any plexiform zone, that is the OPL and the IPL, that is the inner and the outer ones, will be hyper, and then the alternate zones will be hypo. Coming to abnormal reflectivities, you can have reduced reflectivity when there's fluid accumulation, like you can see in CSCR or any kind of retinal edema or sub-RPE fluid. And increased reflectivity we can see in hard exudates, calcification, hemorrhages, fibrosis. We can also see in epiretinal, in the surface area, that is epiretinal and vitreous membranes. We can see it in CNV and RP hyperplasia. And we can also see in RP hypertrophy causing hyperreflectivity of the choroid. We can see an increased reflectivity. So tip 7 is common conditions on OCT. Some of this is already covered, so I'll just go through it quickly. But the common conditions from a PG perspective, especially because it's difficult to cover all OCTs in a 10-minute presentation, but I'll be talking about diabetic macular edema, RVO with macular edema, central serous chorioretinopathy, ARMD, and vitreomacular interface disorders. So coming to diabetic macular edema, you can see diffuse retinal thickening, that is cystoid spaces in the INL and the ONL with a sponge-like appearance. In the bottom scan, you can see some hyperreflective foci, that is hard exudates, or you can even see smaller hyperreflective foci. You can see sometimes a subfoveal neurosensory detachment, as you can see in the first scan. And we have to look out for drill, that is disorganization of retinal inner layers, where there's a lost boundary between the GCL, the IPL, and the INL, and a better outcome predictor than the thickness. So the drill is an important outcome predictor compared to the thickness of the diffuse retinal thickening. And a very important thing that I mentioned was the ellipsoid zone discontinuity, because it is a poor prognostic marker. We can also have similar cystoid macular edema in RVO with CME, where you can have cystoid edema, inner retinal thickening, and in chronic cases, you can have thinning. In the first scan, you can see some shadowing as well because of the hemorrhages, and that can also be seen in fresh cases of BRVO or CRVO. CSCR, again, very well covered in the previous talk as well, is a dome-shaped neurosensory detachment, which you can see in the first picture, which is in between the RPE and the neurosensory retina. So it's a neurosensory detachment, and it's important to locate this fluid, especially when you're reading out the OCT scan. It can have presence of PED. You can see in the second one, there is a small pigment epithelial detachment. In chronic cases that you can see in the bottom, you can see there'll be ellipsoid zone loss. Of course, visual acuity will be low in these patients, and treatment will be based upon the chronicity and the symptoms. ARMD is another important case for postgraduates. The first picture you can see drusen, that is dome-shaped RPE elevation. So you can see in the bottom OCT, there are multiple elevations of just the RPE, and this is suggestive of drusens. In geographic atrophy, that is the later stages of dry AMD, you can see RPE loss with hyperreflective choroid. In case of wet AMD, you can see fluid in the intraretinal or subretinal fluid space, which is suggestive of active CNVM. And there can be different PED types, that is serous, fibrovascular, and drosenoid. You can see the first picture shows us a fibrovascular drosenoid and is suggestive of a type 1, that is a sub-RPE. And the bottom one is suggestive of a type 2, that is subretinal CNV. You can also have presence of subretinal hyperreflective material, which can be either active CNV or can be later in scar or fibrotic cases. Now, type 1 and type 2 are OCT classifications, but they're no longer very useful, and type 3 as well, no longer very useful for treatment purposes, because we anyway will be using anti-VEGF in these cases. Also, a quick touch upon polyportal choroidal vasculopathy. So if you see a sharp peaked PED with a notching or a double layer sign, we need to suspect a PCV. Double layered is when you have a flat irregular PED, which you can see in this image, and that is very suggestive of a polyportal choroidal vasculopathy. So vitreomacular interface, I will just go very fast because I think Dr. Manoj showed the exact very similar things as well. The first one is VMA, that is perifoveal vitreous separation with persistent attachment at the macula, but without any retinal distortion. And VMT will be with associated retinal distortion, as you can see in the second picture. So how do you describe the second photo? Is a partial PVD with focal persistent attachment at the fovea, causing inward traction and distortion of foveal contour. It is associated with intraretinal cystic changes, and it is consistent with the focal VMT. So you can also have epiretinal membrane, which is a hyperreflective membrane on the inner retinal surface. It can cause wrinkling and distortion of the foveal contour. And a lamella macular hole, which is irregular foveal contour, which is partial thickness. That is defect of the inner retina alone without a full thickness defect and intact outer retinal layers. And that is how we differentiate between this and macular hole. So when you look at an OCT and you see a gap in the center, always look to see if the outer retina is preserved or it's also lost. Coming to macular hole, this is the full thickness retinal defect, as you can see, and you can have the arms can also have cystoid macular edema or intraretinal cystic spaces, and this has already been covered by Dr. Manoj. But what they might ask you in the exam is couple of the macular hole indices, and two of the common ones that they ask are the hole forming factor and the macular hole index. A hole forming factor of greater than 0.9 and a macular hole index of greater than 0.5 have a good prognosis. Tip 8 is OCT biomarkers and signs. So biomarkers are the way we treat a patient and way we treat an OCT, and very important in ARMD and DME, and also named OCT signs are something that can be commonly asked. So coming to you can take a screenshot of this, it is available everywhere. But what we look for in DME is retinal thickness, which is not as a reliable indicator anymore. Disorganization of inner retinal layers, hyperreflective foci, presence of hard oxidates, the pearl necklace sign, which when located subfoveally has a poor visual outcome. Subfoveal neurosensory detachment, which is said to respond well to both anti-VEGF and steroids. However, there are contrasting studies in that. And very importantly, in these cases, the integrity of the ellipsoid zone or the external limiting membrane, because this can tell us what the visual prognosis will be. So, and you also have to look at the vitreomacular interface and the taut posterior hyaloid membrane, which can lead to poorer prognosis and probable need for surgical management. And some other prognostic markers are also present. Similarly, in ARMD, there's intraretinal fluids, subretinal fluids, pigment epithelial detachment, subretinal hyperreflective material, which can be either active CNV or fibrosis, like I mentioned. It's associated with poorer visual acuity, hyperreflective foci, ellipsoid zone loss. And in the bottom scan, you can see these round outer retinal tubulations. They're called ORT. This is a sign of a chronic inactive disease, and this is not a sign of active disease. So we do not need to treat when you see ORTs. And again, subretinal fibrosis can also occur. So this one is coming to known OCT signs. There are multiple OCT signs, but I just wanted to touch upon one of them, which is the flying saucer sign. Specifically, I wanted to touch upon this because it was asked in my exam. And this can be typically seen in HCQ toxicity. That is preservation of the outer retinal layers only subfoveally, with perifoveal loss of the ellipsoid zone on both sides of the fovea and the line scan. There are multiple named OCT signs such as ILM drape sign, pearl necklace sign, etc. And some of these might be asked in the exam, so they're important to remember. Difficult to cover all of them again in this OCT, in this class. So tip 9 is know your artifacts. Not everything is just abnormal. We also have to make sure we are not missing out on something that has been done wrong. The scan itself has been done wrong. For example, incorrect segmentation. You can see in the first two pictures here, there's not a correct segmentation of the inner and outer retina. You can also have mirror artifacts, especially in myop, where the entire retina is flipped over, and that again gives us a wrong impression. Out of register artifact, where you cannot see the bottom outer retina, the RPE itself, and blink artifacts, where you can see like a split in the center. And this is suggestive of the patient took a blink and the OCT was done during that. So there can be patient-related artifacts, operator-related artifacts, or software-related artifacts, and these first have to be ruled out before we comment that the scan is abnormal. Tip 10, and this is the most important, especially from exam perspective, to summarize and correlate. So every time you see an OCT scan, look at the name, age of the patient, date of the scan, type of the OCT, type of the scan, signal strength, and the eye involved, and quantitatively the retinal thickness, that is the CMT, and qualitative start from the vitreoretinal interface, foveal contour, inner retinal changes, outer retinal changes, RP Brooks membrane complex, and the choroid. So just giving two examples of how we can comment in the exam about these patients. Other than the name, age, the sex, the eye, and the signal strength, I'm just going to talk about the OCT alone. So start with the vitreoretinal interface. In this patient, it's a 50-year-old female who's diabetic and hypertensive with a sudden decrease in the central vision. In this OCT, you can see in the vitreoretinal interface as an incomplete PVD. The foveal contour is obviously lost with a dome-shaped elevation of the central macula. In the inner retina, you can see multiple hyporeflective intraretinal cystoid spaces, predominantly in the INL and the OPL and with associated retinal thickening. In the outer retina, it's stretched over the cystoid spaces, but the ellipsoid zone is relatively preserved. You can see the ellipsoid zone here. The entire hyperreflective line looks absolutely intact, but probably mildly distorted because of the cystic spaces. So the RP Brooks complex is also continuous and intact, and the choriocoplaries and choroid have normal reflectivity. So this patient was diagnosed with OSCRVO with cystoid macular edema, and this is how in an exam when they ask you to read an OCT, and this is the systematic way you follow to read the OCT. Coming to another example, a 35-year-old with metaporphyria for 2 weeks. In the top scan we'll talk about, the vitreoretinal interface appears normal. The foveal contours lost with a dome shade elevation of the neurosensory retina. The inner retina layers appear preserved, and the outer retina, there's a large hyperreflective subretinal space suggestive of a neurosensory detachment, and the outer retinal layers themselves are elevated but appear structurally intact. The ellipsoid zone in this patient appears intact, although it's elevated. So the RP Brooks is continuous and there's no obvious PED noted in this scan, but you can see it in a scan right above. There is a small PED there, which is an irregular RP contour in that area. Choriocapillaries and choroid appear thickened in this, and that is important to see that this is a pachychoroid disease with increased choroidal reflectivity suggestive of pachychoroid features. So this is how you read a scan in any normal patient. So the three critical things examiners expect is through retinal layer anatomy recognition, fluid compartment localization, image quality assessment. So also recognizing the artifacts and making sure that we're not commenting on the artifacts as abnormal. So master this, that is a 5-step systematic OCT interpretation for the exams. 1 is quality check, 2 is layer architecture, 3 fluid localization, 4 photoreceptor status, which is very important to check the ELM and the EZR integrity. And step 5 is the interface, that is the vitreomacular interface for any changes and the choroidal changes and thickness. Thank you. Reading an OCT should be a systematic manner with a clear idea of what you're reporting. And it's always important to clinically correlate before you provide a diagnosis. Thank you.
Thank you so much, Dr. Mohan. It's a very important topic for the PGs, and as you rightly said, anatomy of the OCT of the various layers is very important for them to recognize, and the various pathologies grossly and the minor things in that as well. Thank you so much.
Thank you. Thank you so much.
We can have the next topic, please.
Next we go on to anti-VEGF therapy, another important topic. And for this, I would like to invite Dr. Divya J. Ma'am, please share your slide.
Yes, sir.
Dr. Divya J is a consultant, a retina consultant at Arvind Eye Hospital.
Good evening, everyone. My topic for today is anti-VEGF drugs. I'm Dr. Divya, consultant vitreoretinal surgery in Arvind Eye Hospital. I thank Dr. Prafulla sir and DOS team to give me this opportunity. We all know that hypoxia increases VEGF, and it in turn increases the angiogenesis, which predisposes to proliferative diabetic retinopathy. And again, VEGF can increase the vascular permeability and cause macular edema. So there are many members in the VEGF family. One of the most important member is the VEGF-A, which is responsible for the angiogenesis, vasodilatation, and chemotaxis. Another one is the placental growth factor, which causes inflammation of the eye and vasculogenesis. One of the important isoforms of VEGF we have to remember is the VEGF-165. Before we move on to the further slides, I would like to cover some basics. VEGF is a dimeric protein which binds to VEGF receptors. VEGF receptor have ectodomain and endodomain. This VEGF binds to the ectodomain and activates the tyrosine kinase, which in turn causes angiogenesis. So we all know that a monoclonal antibody has a FC and a FAB portion. FAB binds to target, whereas the FC carries out effector function. So anti-VEGF agents have many indications, like they are used in neovascular ARMD, PDR, DME, vascular occlusions, retinopathy of prematurity, Coats disease, CNVM, and chronic CSR. It is also used in iris neovascularization.
There are many contraindications. The systemic ones are any recent thromboembolic event, any known hypersensitivity to the drug, pregnancy, lactation, and any co-administration of live vaccines. There are many ocular contraindications like any active ocular or periocular infections, fibrovascular proliferation in the macular region. So the adverse events, ocular adverse events of anti-VEGFs are endophthalmitis, intraocular inflammation, raised IOP, ocular hemorrhage, cataract, retinal detachment, and vascular occlusions. And the other systemic adverse events are thromboembolic embolic events like stroke, MI, proteinuria, acute decline in renal function. So before we move on to the procedure, we should know where to inject. So injection site differs based on age groups, and in adults, it depends on the lens status. So we inject at 3 mm from limbus in aphakic eyes, 3.5 mm in pseudophakic eyes, and at 4 mm in phakic eyes. So firstly, we explain the procedure to the patient and get their consent. Under sterile aseptic precautions, so speculum is used, topical povidone iodine and topical anesthetics is instilled. A 30 gauge needle is used. We usually inject in the infratemporal quadrant. Again, it depends on the lens status, how posterior you're going to inject from the limbus. The 30 gauge needle is advanced towards the center of the eyeball and gently injected into the mid-vitreous cavity. As soon as the needle is removed, sterile cotton swab is placed over the injection site. IOP and central retinal artery perfusion is checked. Topical antibiotics are prescribed. So moving on to the anti-VEGF treatment regimes, there are Pro-Renata regime and treat and extend regime. So the treat and extend regime is we give monthly injections till the stability is achieved, and the follow-ups are gradually extended by 1 to 2 weeks based on the central macular thickness and best corrected visual acuity. And we keep extending the follow-up till 12 weeks, that is 3 months. If it worsens, then in between, then we reduce the follow-up visits. Whereas in Pro-Renata or the PRN regime, it is also known as and when required regime, where the first 3 injections are given in loading dose in monthly interval. But the patient is followed up every month after that, and we inject only when the patient needs it. So we are going to discuss some important anti-VEGFs today. Firstly, it's pegatinib. It is a 28 nucleotide RNA aptamer. It was FDA approved in 2004. Next, moving on to bevacizumab, which we all know as Avastin. It is a recombinant humanized monoclonal antibody. It is active against all isoforms of VEGF-A. It has a molecular weight of 149 kilodalton. It has been only approved, FDA approved for metastatic colorectal cancer in 2004. Currently, the ophthalmic use is off-label. Its systemic half-life is 20 days. Moving on to ranibizumab, it's a recombinant monoclonal FAB fragment of antibody. It is FDA approved in 2006 for wet AMD and DME in 2012. It has a systemic half-life of 9 days. As it is only an FAB fragment, its molecular weight is only 48 kilodalton. So there are trials like Resolve Right and RISE trials, which was conducted in DME patients, which all show similar results where strong visual acuity gains and improvement in retinal anatomy was achieved with ranibizumab when compared to sham injections. Again, trials like Bravo and Cruise were conducted in retinal vascular occlusion patients, where again ranibizumab was superior to patients who received sham injections. The visual acuity was better in these patients. So again, trials were conducted in ARMD patients, where anchor trial showed that ranibizumab had a better visual gain as compared to patients who received PDT. And Marinard showed that ranibizumab showed better visual acuity as compared to patients who received sham injections. Now moving on to aflibercept. It is a recombinant fusion protein. It binds to extracellular domains of VEGF receptor 1 and 2, and those parts are fused to the FC portion of the human IgG. So this binds to VEGF-A, B, and placental growth factor. It's given in the dose of 2 mg per 0.05 ml. It is FDA approved for wet AMD and diabetic retinopathy. Wet AMD in 2011 and diabetic retinopathy in 2015. So we must know what is VEGF trap. Aflibercept has unique binding action and it binds to both sides of the VEGF dimer, forming an inert one-to-one complex termed as VEGF trap, as you all can see in the diagram. So there were trials conducted in DME patients. Here in Da Vinci, it showed that aflibercept had a better visual acuity improvement as compared to patients who received a macular laser photocoagulation. Similar results were seen with VISTA and VIVID studies. Moving on to brolucizumab, it is a single chain variable fragment and it's given in the dosage of 6 mg per 0.05 ml. It has a molecular weight of 26 kilodalton. It is one of the it is the anti-VEGF which has the smallest molecular weight currently what we are using, and it is FDA approved for wet ARMD in 2019 and DME in 2022. So the only issue which we have faced with the brolucizumab is the intraocular inflammation, as published in American Academy of Ophthalmology. But VRSI study group have published in Indian Journal of Ophthalmology that the incidence of intraocular inflammation was lesser in Indian eyes as compared to that of Caucasians. And so there were Kestrel and Kite trials done in DME patients, which showed that brolucizumab provides comparable visual gains to aflibercept with fewer injections. Again, Hawk and Harrier studies done in ARMD patients have shown that brolucizumab was non-inferior to aflibercept in visual function, and anatomical outcomes favored brolucizumab over aflibercept. Moving on to faricimab, it is a dual mechanism antibody with two different antigen binding fragment regions, which targets VEGF and angiopoietin 2, connected to a single FC domain. The dosage we use is that 6 mg per 0.05 ml. It has a molecular weight of 149 kilodalton, and it is FDA approved for wet ARMD and DME in 2022. So again, an ongoing trial, that is yosemite Rini, was done in DME patients. It assesses the 2-year efficacy, durability, and safety of intravitreal faricimab with treat and extend dosing up to 16 weeks in DME patients. Then again, TENAI and LUCERNE studies have shown that faricimab has shown comparable outcomes as that of aflibercept in ARMD patients. So these are some of the AMD treatments in phase 3 clinical trials. There are a lot of named studies. This might be a question in a Viva or any MCQs. So there are many newer agents. One is that case 301, which is an antibody biopolymer conjugate, that is ranibizumab with polymer. It is having a long-lasting effect. And the next one is the THR-149, which acts on alternate pathway, which is plasma kallikrein inhibition, which is directly involved in the DME pathology. The next one is the OPT-302, which is used for recalcitrant patients to anti-VEGF. It attacks the VEGF-C and the D. It has shown to reduce SRF and improve visual acuity in CNVM patients. And the next one is the RGX-314, sorry. It is a subretinal injection, which this can decrease the necessity of repeated injections. And the other one is the oral lamivudine, which is an oral inflammasome inhibitor, which has shown significant improvement in vision in patients with center involving DME. So this is a summary of all the drugs which we have discussed earlier. And referring through to, I've referred some of the previous year DNB question papers, and these are some of the commonly asked questions. We have covered most of it, and thank you.
Thank you so much, Dr. Divya. So this is a very important topic for PGs, and so they should know the names of the basic anti-VEGFs, the newer ones which are coming, and the various trials. These are very important. Thank you so much.
Thank you, sir.
We go on to the next topic, Dr. Ankur.
Yeah, so the next topic is going to be on anti-uveitis, differential diagnosis and workup. workup, and for which I would like to invite Dr. Arshi Ahmed.
Hi, Dr. Ankur. Good evening, Dr. Shishir. Thank you for having me here. Can I start?
Yes, ma'am.
Can you see my slides now?
Yes, ma'am.
Yeah. So very good evening to all of you. I think we had wonderful lectures on retina, and it is time to move to a different subset altogether, that is uveitis. So I think I am speaking first on anterior uveitis, and it will be followed up, I think, with other talks by other wonderful speakers. So before we dive into anterior uveitis, the objectives of my lecture would be to make you understand the basic classification of uveitis, focus on anterior uveitis with case-based learning. So as we all know, the anatomy of the uveal tract from anterior to posterior includes the iris, the ciliary body, and the choroid. And this distinction is important to understand because the way we classify uveitis now is by the standardization of uveitis nomenclature, that is called as the Sun classification, which is bound to be, taken up by your examiners once you are across them. Because the moment you start classifying uveitis, you have to know that it could be anterior, intermediate, posterior, or panuveitis, depending on which part of the uveal tract is the primary site of localization of the uveitis. So as the term itself means anterior uveitis, it would mean either inflammation of the iris, so it is iritis, iridocyclitis, where there is inflammation of the iris, and some part of the anterior ciliary body is affected, and it could also be cyclitis, that is, there is involvement of the anterior part of the ciliary body alone. So I have just put a small video here to show you how one would examine a patient with anterior uveitis. So just let us have a quick look. So when you're examining the patient, it is important that a good slit lamp biomicroscopy is done. Once you have done a good diffuse illumination examination, important thing is to increase the magnification and illumination, reduce the size of the beam to 1 × 1 millimeter. And this part here, what you see is the optical cross section between the corneal and the lens beams. So that is where you must focus. And if you focus behind the lens, you see the anterior vitreous. So these are two important areas in the anterior chamber and in the anterior vitreous, where you want to look for these white dots, which are the cells. If they are brownish, they could be pigments. So without a good slit lamp biomicroscopy, you cannot pick up a case of anterior uveitis. So it begins there. And this diagrammatic representation I have put here to make you understand that this is how cells would look like, white dots which are floating around. Whereas flare is something which is this beam which you see here between in the optical cross section. So normally the anterior chamber is supposed to be optically clear. You wouldn't see any beam as we saw in the previous video, but here you see this well lit up beam, which is indicative of flare, which basically happens because of a breakdown in the blood aqueous barrier and presence of the anterior chamber. So also from an exam point of view, it is important that the Sun grading of anterior chamber cells and flare is well known to you, and you are able to utilize it when you are grading or presenting your case. Another important thing you should know is there's something called as a laser flare photometer, which is an objective way of assessing flare, although you cannot count cells with it. Cells you have to manually count or give a rough estimation. So now let us just see a few cases of anterior uveitis so that we understand what are the different types of etiologies one may come across very commonly in the OPD. So if you see this patient here, a 30-year-old male patient who comes with sudden onset pain and redness and severe photophobia. So when you examine this patient now, you see there is ciliary congestion. There are cells in the anterior chamber and you see a mid-dilated pupil. Fundus examination was normal. So now what is our possible next line of questioning for this patient once you have seen this much. So because considering an acute onset, unilateral, sudden onset, we do ask first for a history of trauma. And this patient did have a history of trauma with a shuttlecock. So when you see the same patient now on a retro illumination, even if you have missed earlier, you cannot now miss the sphincter tears which are present on the pupillary border. So it is a case of a traumatic anterior uveitis. So when you are seeing a case of traumatic anterior uveitis, a few points which you should know is it is a self-limiting condition. Only topical treatment is usually required. It is very, very important that you have a look at the retina. It is also important that you look for other telltale signs of trauma when you're dealing with traumatic anterior uveitis. There could be injury to the pupil, as we saw. There could be recession, like or a foreign body in the angle. Very important to look at the retina. You may be dealing with commotio retinae or sometimes even giant retinal tears. So unless and until you have seen the posterior segment, you cannot label the patient to be having anterior uveitis. And it is important that you ask for a history of trauma in all acute cases of uveitis, especially in new cases. The prognosis is usually good unless and until there is associated injury, and no systemic investigations are obviously required. Moving over to the next case. So this is a 40-year-old male patient and comes to you with a 3 days duration history, in this particular left eye. And he has also got a recurrent history of repeated attacks of pain and redness in both eyes alternatingly. So now when you see this patient here, what do we see? Of course, there's a lot of ciliary congestion. Inside the anterior chamber, you see some layering of a whitish material here. And again, you see some fibrinous material over the anterior lens capsule, but appears to be already scrolling up, retracting. So this is retracting fibrin associated with hypopyon. So in this particular age group with this particular history, the next history which you would like to ask is for a history of backaches with stiffness on inactivity. And this particular patient checked all the boxes, was investigated, and was then found to be HLA-B27 positive. So this is a classical case of HLA-B27 associated uveitis. It is important to remember that this particular uveitic entity is acute, anterior, fibrinous, and recurrent. So this is what is expected of you when you are talking about a case of HLA-B27 disease. The management initially, of course, involves aggressive topicals. You cannot control it with a low dose, low strength steroids. You should start the patient on topical prednisolone acetate 1% and cycloplegic mydriatics like atropine and homatropine. And of course, oral therapy may be required in patients wherein you are unable to control the inflammation or there is spillover inflammation into the anterior vitreous. You may require oral steroids. Without a rheumatology consultation, usually we do not manage these patients alone. And along with them, in conjunction with them, we do recommend starting either immunosuppressives or biologics and even JAK inhibitors, which is a new class of drugs available now to manage these patients who have associated ankylosing spondylitis. So the points to learn or to take away from HLA-B27 uveitis are acute onset and dramatic presentation. Usually young to middle-aged males are the most common subset of patients who are affected. They will have a history of spondyloarthropathy, so it is up to us to elicit that history. Also, very important thing is when you are seeing a uveitis patient, look at the patient as a whole. The patient may walk in with limited neck and spine movements. You may see stiffness of already obvious, and that is a very important clue. Usually requires, as I said, topical treatment, but you may require oral therapy, which is a case-to-case decision you have to take. So as an other important point for the exam going postgraduate to know is what are the other causes of hypopyon uveitis. So one, as we saw, could be HLA-B27 disease. There is a mobile hypopyon you may see in Behçet's disease. Of course, infection like endophthalmitis can cause hypopyon uveitis. Rarely drug-related like rifabutin. Pseudohypopyon is something which is not a true hypopyon because there is no inflammatory cell present in the anterior chamber. It is actually the tumor cells which you are seeing in patients who may have retinoblastoma or even lymphomas. Pigmented hypopyon is a very rare condition, but you may come across in a patient who has listeria or tubercular infection. Blood-tinged hypopyon as well, you can see in patients post-surgery or with infections with Klebsiella or Serratia, and in patients who have leukemias. So moving over to the next case of anterior uveitis. So this is a 32-year-old male who comes to you with a complaint of blurring of vision alone.
important thing to note here is that this patient has no history of pain or redness and has been prescribed multiple courses of oral and topical steroids. So now when you see this typical picture here, I think it is a giveaway. So here, this is a case of Fuchs heterochromic iridocyclitis. And why do I say that? Because this patient, if you see the pattern of keretic precipitates, you see that these are diffuse. So these are present all over the cornea. These are all non-pigmented and they are stellate if you see them under high magnification. So this is a classical triad for describing the KPs which you see in Fuchs heterochromic iridocyclitis. The management of these patients is straightforward in the sense that usually you do not need to treat them aggressively. Observation is key here unless and until the patient has associated glaucoma or if the patient has a visually significant PSC, you may require surgical intervention. Otherwise, these patients usually can be managed with observation. So it is a commonly misdiagnosed and overtreated condition. So it is very important that you know that you're dealing with a Fuchs patient vis-a-vis intermediate uveitis. So if it is an intermediate uveitis patient, the patient may have associated CME, may have other signs of uveitis like posterior synechiae, etc., which are never seen in patients with Fuchs. So it is important that you assess the distribution of KPs. Another important thing which you may see, why I put up this photograph, is you see the presence of multiple iris nodules in this patient who has a near total cataract and has Fuchs uveitis. So I would also like to leave you with a few points for your exam, where you should know what are the other causes of iris nodules other than Fuchs. So you may see it in any granulomatous uveitis like sarcoid, for example. It could be totally non-uveitic. You may see some spots on the iris in neurofibromatosis or Down syndrome. Rarely seeding, that is tumor deposits itself in the iris stroma, can be seen in patients with malignancy. So this is a patient where I have put in a photograph of a patient with sarcoid uveitis. You see these nodules on the iris, on the pupillary border. So these are called as Cope's nodules. On the other hand, if you see these nodules in the stroma, we call them as Busacca's nodules. Rarely, you may also see nodules in the angle, and these are very typical of sarcoid anterior uveitis, and these are called as Berlin's nodules. So as we go over to the next case, before that, I would like to leave you with a very, very important point when we are talking about anterior uveitis is the keretic precipitates, which are basically clusters. Whenever there's inflammation in the anterior chamber, lymphoid cells and macrophages, epithelioid cells, etc., may all clump up and get deposited on the corneal endothelium because of convection currents in the aqueous. So what you see here helps you describe the disease and narrow your differentials down. So it is very important that you assess their size, their color, distribution, pigmentation, and whether there are any associated cells or flare. So in this particular patient, you are seeing large keretic precipitates, which are classically described as mutton fat keretic precipitates, and most of them are in this triangular pattern here, which is called as an Arld's triangle. So this is very typical of a granulomatous uveitis. The previous examples which we have seen, like HLA-B27 or Fuchs, as you saw, were all non-granulomatous keretic precipitates. This is a very representative image of granulomatous uveitis. So now moving over to a next case, which is again very, very typical. You see a 42-year-old male patient who comes to you with an acute history of 5 days duration of a red eye. So when you see this patient now on the slit lamp, you're seeing a lot of ciliary congestion. You see the corneal endothelium studded with pigmented KPs throughout, and a lot of anterior chamber cells, a normal fundus. But the key thing to note here is that the intraocular pressure is extremely high. So I think this is a very, very typical situation which you would come across when you are dealing with viral uveitis. So when you are suspecting viral uveitis, an important tool at your disposal is an anterior chamber tap, and you can do a polymerase chain reaction study to look for your particular offending agent. So in this particular patient, it was found to be positive for herpes simplex virus 1. So when you are dealing with viral anterior uveitis, it is important you note that along with the typical management you would afford any patient with anterior uveitis, you may have to add anti-glaucoma medication. And the most important part is appropriate antiviral drugs. So appropriate antibiotics may have to be added in any patient who has got an infectious uveitis. Corticosteroids usually are not required. That is oral therapy. You may require it again if there is a spillover vitritis. So the points to learn from any case of viral anterior uveitis are: look for corneal hypoesthesia, that is reduced corneal sensations. Look for diffuse pigmented KPs as we saw in the previous picture. Another important point you should know is a coin-shaped keratic precipitate, which is very, very typical of a CMV anterior uveitis. In this picture, which I have put up here, you see a typical pattern of iris atrophy, which is sectoral, and this is particularly seen in patients who have got herpes zoster infections. High intraocular pressure is another giveaway, and aqueous sampling for PCR is an important tool which can be utilized. Another thing which you should know is if you see a patient at extremes of age, you should also again step back and look at the patient. So this is a patient here. I have put up this image so that you can understand that not only a young patient, but even an old patient can have viral anterior uveitis. In this particular patient, it is herpes zoster. You see the typical lesions on the same side of the face, and you also see lesions on the tip of the nose. This is called as Hutchinson sign. So this is very, very typical of herpes zoster ophthalmicus. So look at the patient as a whole when you are seeing a patient of uveitis. And very importantly, in viral uveitis, always look at the posterior segment because there is a very high risk of these patients having acute retinal necrosis. So you cannot make a diagnosis of anterior uveitis unless and until you have excluded involvement of the posterior segment. Another important point which you should take away today is what are the IOP fluctuations in uveitis, especially in anterior uveitis. So intraocular pressure could be high, could be low. So these are the various conditions I have just put up here for easy reference. Along with this, it is also important to know the mechanisms. Why is the pressure high or why is the pressure low? So these are important things which can come up in your examinations. Next is, again, another extreme of age is a young child, a 10-year-old girl child who comes with mainly complaints of blurring of vision. When you examine the patient, you see a lot of deposits on the cornea in this typical appearance. This is called as band-shaped keratopathy. You see a complicated cataract at the back and all these calcium deposits in the interpalpebral zone. You even actually can see the Swiss cheese kind of appearance, which are the areas of clearing you may see. So this is a typical case of probably JIA-associated uveitis. And when you ask the patient for a relative history, majority of the times they will give you a history of joint pains or swelling. So when you're dealing with JIA-associated uveitis, it is very, very important that these patients are worked up thoroughly. Roughly, at least, these are the basic investigations you would want to do. Of course, there may be other investigations you may require in a case of pediatric anterior uveitis. But again, characterization of the disease, the clinical features that you're seeing would basically guide you towards your investigations. When you are asked about a case of a GIA-associated uveitis, it is very important to understand that these patients usually come with white eyes. So pain and redness is not the priority complaint here. They may come to you with a complete blurring of vision. It is important that these patients are started on appropriate immunosuppressive. So the mainstay of therapy here is not steroids. It is important to learn that it is immunosuppressives, either methotrexate, mycophenolate. We are in the era of biologics now, so it is very, very apt if you say biologics as well. Of course, along with topical agents, but the rule here is that you have a very, very low threshold for cells. So try to reduce the cells in the anterior chamber and follow up these patients long term because they are prone to develop various complications like amblyopia, as we saw, band-shaped keratopathy, glaucoma. Cataract surgery is in itself a separate topic to be dealt with in patients who have pediatric JIA-associated uveitis. Whether or not you implant an IOL would depend on the age of the patient and the degree of inflammation control that you have. So the points to learn from pediatric intermediate JIA-associated uveitis are: look for positives in history and systemic examination. You may require examination under anesthesia, rule out infections and masquerades, and investigate accordingly. Long-term follow-up is key for these patients. So just to leave you with other causes of white eye uveitis other than JIA, as we saw Fuchs, you may also have Bessett's, which can have a mobile hypopyon and many times may have a whiter looking eye, and masquerades. Moving over to the last case. So this is an example of an 80-year-old male patient who has come again to you with sudden onset pain, redness. You see ciliary congestion, cells in the anterior chamber. And when you look at this patient now, you see that the vision is very poor, only hand movements. Other eye is pseudophakic. So here itself, there is a very big clue. So because of one eye being well seen, this patient has neglected surgery for cataract in this eye and has developed leakage of protein from the lens. itself into the anterior chamber and has developed lens-induced uveitis. So in many patients with advanced cataracts, this is something you may come across very commonly. And the treatment here would be immediate surgery for cataract extraction. We do not really wait for the eye to quieten down here because the nidus of inflammation is the lens. So it needs extraction, and IOP monitoring is very important again post-operatively. So look for long-standing cataracts where there is wrinkling or a total mature cataract. Usually these patients have no prior history of uveitis. And ultimately, you may also, you can need to learn about a few other important things like which are the masquerades which can present with anterior uveitis. So you may have retinoblastomas, leukemias, and lymphomas. Another important thing is retinitis pigmentosa. Even these RP patients sometimes can develop anterior uveitis. Drug-induced anterior uveitis is another important subset. You may be asked about it. I have just put up a few photographs of a patient who was using brimonidine and then developed brimonidine-induced anterior uveitis. So biphosphonates, fluoroquinolones, cidofovir, these are very important causes of drug-induced anterior uveitis. So now once you have seen all these various sorts of presentations of anterior uveitis, we can just recapitulate it quickly. So what are the factors which you would usually consider when you are seeing a patient with anterior uveitis? So what is the age of the patient? Which gender does the patient belong to? Is it unilateral disease or bilateral, or is it happening in both eyes as alternating episodes? What is the course of the disease? And etiology. So when you're talking about etiology, what you really want to know is whether it's an infectious disease or non-infectious. So there is a big list under both, and it is important for you to learn and to know that these are the most common infectious or non-infectious entities you would see. A very, very important clue is whether it is granulomatous or it is non-granulomatous. So these are the various conditions, especially in our country where TB is very endemic. TB anterior uveitis is very commonly seen, which is usually granulomatous. Non-granulomatous, a very common thing which you would see is viral or HLA-B27 associated disease. So this is an overall list of investigations which one may need to do. Of course, the important thing to understand is that you have to tailor it to what you are seeing. You cannot go ahead and do all investigations in all patients because it sets up for failure and confusion. So what you see, based on that, you advise investigations. So the basic principles of management of anterior uveitis are that you tackle the inflammation. So for that, corticosteroids are definitely the way to go. There are various corticosteroids. It is important that you know the pharmacology of each and which are the preferred drugs. Next important thing is to tackle the pupil. So here you require cycloplegic mydriatics. One reason is to relieve the accommodative spasm and give the patient symptomatic relief. And another important thing is you want a mobile pupil to prevent posterior synecdoche formation. And as I said, investigate according to what you are seeing and then manage once you have arrived at a diagnosis. So the key takeaways from this talk is that inflammation confined only to the anterior segment is anterior uveitis. Look for cells. Flare is never an indicator of disease activity. Anterior uveitis is a diagnosis of exclusion because you need to look at the posterior segment first. Thorough history taking is of utmost importance in any patient with uveitis. Treatment is primarily topical. Anti-glaucoma medications can be added as required. Oral therapy, either in the form of anti-inflammatory agents or antibiotics, have to be added as per the etiology you see. Complications can happen very rapidly, even in patients who have anterior uveitis alone. As we saw in the previous case, band-shaped keratopathy, synecdoche formation, glaucoma. Here I have put up a picture with iris bombay, which you may see in the emergency in a patient who has anterior uveitis and 360-degree synecdoche. On the other hand, hypotony is a dreaded complication, especially you may see it in HLA-B27 and JIA-associated uveitis. So I just leave you with a few exam questions which you should know, which can be asked even in theory and in your practical exams. And so these are a few here. So thank you very much for patient learning, and I wish good luck to everyone.
Thank you, Dr. RC. That was a wonderful, and I think for students, you have to remember uveitis can come as a long essay type of question also, apart from being a short case, long case. And ma'am rightly highlighted all the clinical pearls that is important for exam perspective. So Dr. Ankur, I think let's go to the next talk. Thank you so
Thank
much,
you very
ma'am.
much. Thank you very much, Dr. Praful and Dr. Ankur. Thank you.
Thank you.
Thank you, ma'am. And very good night, ma'am.
Yeah, good.
Let's go to, yes, ma'am. Let's go to our next talk. Next talk is going to be Dr. Pooja Bansi, ma'am. He's going to talk about posterior uveitis, differential diagnosis, and workup. Dr. Pooja Bansal ma'am right now is a senior consultant of Retina Uvea, Center for Sight, Dwarka, Delhi.
Hello, and thank you, Dr. Praful, for giving me the opportunity to talk. And so I'll be discussing posterior uveitis, how to go about the workup and the differential diagnosis. Is my slideshow visible?
Yes, Pooja, it's visible.
Yeah,
Go ahead.
yeah. So posterior uveitis, according to the Sun classification, the site of inflammation is either retina, choroid, retina vessels, or optic nerve head, or there can be a combination of one or more sites. The etiological is mainly infectious or non-infective, and the infectious is commoner are the toxoplasmosis, viruses like acute retinal necrosis, progressive outer retinal necrosis, CMV retinitis, and post-fever retinitis. In the bacteria, the commonly seen cases are tubercular uveitis, syphilis. Rarely we see cat scratch disease, and in fungal, common are the Candida and Aspergillus uveitis. Non-infective causes usually have some associated systemic association like sarcoid, Behçet's, VKH, and white dot syndromes. So we have to have an algorithm approach. First of all, we have to define the morphology of the lesion, and then we have to make a working clinical diagnosis. And then we go back and take the retrospective history, and then accordingly we mesh the patient and review all the causes of condition and compare with existing uveitis patterns. That what we call is a differential diagnosis. And then we confirm the diagnosis by ordering certain, tailored lab workups as well as the ancillary ocular investigations. As my previous speaker told, the primary symptoms in posterior uveitis will be slightly different from the anterior uveitis, that they typically won't be having any redness, pain, photophobia, or watering. Until unless the patient is having posterior scleritis, the primary symptoms will be floaters, blood vision, maybe some metamorphopsia if macula is involved. So it is important to assess the duration in the onset. Is it sudden onset or chronic, insidious? Is it unilateral or bilateral? Did the patient had similar previous episode, and what was the treatment given and treatment response in the past? So important systemic history, which one should take either in the beginning or after you have examined the fundus, and then you can come back and take a targeted retrospective history. In an endemic country like ours, one should take for a TB exposure. If the patient is having some history of fever, weight loss, or cough. If there are autoimmune disease, then patient might be having associated arthralgias. Again, in TB and sarcoid, they may have some respiratory symptoms in form of dry or productive cough, some dyspnea. And if oral or genital ulcers are there, again, it can be Behçet's or syphilis. Skin rash, again, patients may have SLE, may have sarcoid, may have syphilis. If the patient has some prodrome flu-like illness, can have VKH, especially in females. If the patient is giving some travel history to some forest area or hilly areas, then can have post-fever retinitis. If there is some homosexual history or other sexual history, rule out syphilis or immunocompromised status. It can also rule out PON, CMV, and fungal. If the patient had cats or pet exposure, one should think of toxoplasmosis or Bartonellosis. Then coming on to the ocular examination, one should look for the visual acuity, intraocular pressure. If any associated signs of anterior chamber inflammation, vitreous will typically show either it will be a clear vitreous, there may be some active vitritis, or some old debris or some exudates. And fundus examination, we have to, as I discussed, we have to see which part of the fundus is involved or any associated macular edema, hemorrhage. So the most common is the two entities are retinitis and choroiditis. So the PG has to understand what is the difference in the morphology. A retinitis will be a typical whitish inflammatory fuzzy lesion with ill-defined borders. The underlying choroid will be obscured and the retinal vessels will be passing or dipping through the lesions, and they will disappear in the lesion. And it will be usually associated with vitritis. Obviously, we have to see whether it is unilateral, bilateral, focal, multifocal, necrotizing, or non-necrotizing. Whereas in the choroiditis, there'll be plaque-like flat lesions, dull yellowish or orange, and with distinct or indistinct borders depending upon their active or inactive, and they'll be deeper to the retinal vessels. So in all the lesions, you can see the overlying vessels. And if the vessels are elevated, then we are dealing with a granuloma. They have relatively less or no vitritis. Then we have these interchangeable terms depending upon the retina is involved first or choroid is involved primary as retinochoroiditis or chorioretinitis. Now coming on to some common posterior uveitis conditions. The first is toxoplasmosis, where you have dense vitritis, which is called typical headlight and fog appearance. If the patient had some old satellite lesion, as you can see in this picture, then you can see this old satellite lesion, and then you have this active lesion in the center. And if the patient is having newly acquired infection, then there'll be a chorioretinal scar will be absent. So in this case, normally the diagnosis is clinical, and you can do some serology, IgG and IgM antibodies. And sometimes if you have atypical presentation or the patient is not responding to treatment, then you can take an aqueous fluid or a vitreous fluid for PCR analysis. Treatment is you have to give anti-parasitic drugs like the trimethoprim sulfamethoxazole combination or clindamycin oral or intravitreal along with oral steroids to be started 24 to 72 hours later. Then coming on to the herpetic retinitis, they are typically necrotizing and non-necrotizing retinitis, and the risk factors are active or past history of herpetic infections. So again, these are peripheral tongue-shaped lesions starting in the periphery and then they're spreading in the center. You have certain diagnostic criteria which need to be followed, major and minor criteria, to make a diagnosis of acute retinal necrosis, that one or more foci of retinal necrosis starting from the peripheral retina, rapid progression, circumferential spread, in immunocompromised patients, and the necrotizing retinitis starts at the posterior pole and spreading towards the peripheral retina. Typical the cracked mud appearance. So, am I audible?
Yes, ma'am.
Okay, thank you. So both these acute retinal necrosis and PON, they are the clinical diagnosis and they are considered ocular emergencies. We need not to wait for any ocular or systemic investigations to start the treatment. However, we can do an aqueous or vitreous fluid tap again if the patient is not responsive to treatment. So the treatment is initial IV acyclovir or oral valciclovir for 10 to 14 days and then followed by oral therapy for at least 6 weeks. And then some patients, they require maintenance therapy also. Another category is CMV retinitis, which is the most common cause of retinitis in immunocompromised patients with low CD4 counts, typically less than 100 cells, and which are commonly seen in patients of leukemia, organ transplants, or HIV patients. Again, the vitritis is absent or minimal because they're immunocompromised, and they can have hemorrhagic retinitis appearance, which is known as pizza pie or tomato ketchup or brush fire experience. Or they can have granular appearance when they are in the peripheral retinitis or healing phase, or they can have this frosted branch gingivitis. Again, this diagnosis is clinical and needs urgent treatment in the form of intravitreal ganciclovir therapy and biweekly intravitreal ganciclovir injections. Then coming on to Bartonellosis, it is again a clinical diagnosis not very commonly seen. History of exposure to pets and cats, if elicited, supports the clinical diagnosis. And if available, one can do the serology for Bartonella. And it typically presents as a neuroretinitis. That is, you have disc edema, you have retinitis, and along with macular star formation. And if there is high clinical suspicion, we need to initiate antibiotic treatment. This is another entity which is usually bilateral, which is called post-fever retinitis. You are seeing multifocal retinitis patches. If you are seeing such lesions along with some macular edema, then you have to rule out either the patient usually they present after they have they have recovered, or they are in the second or third week of the illness, like typhoid, dengue, chikungunya. So you have to take the history, and these are just to show the angiograms of retinitis patients, how the lesions, the edges start leaking in the early frames itself. And again, these diagnoses, if the patient is already carrying the investigations, you need not to investigate them. Otherwise, you can on to intraocular tuberculosis, which is very common in our country. So different uveitis patterns in intraocular tuberculosis are serpiginous-like choroiditis, multifocal serpiginoid choroidal, miliary choroidal tuberculomas, or retinal vasculitis. So these are the different pictures. You can see the serpiginous-like choroiditis. That means it is spreading like a serpentine pattern, and then a multifocal serpiginoid, that they are first starting as solitary lesions and they are coalescing and they are spreading. Usually they start in the periphery, and in the late stages they involve the macula if not treated in time. And this is very typical of the tubercular granuloma. You have elevated subretinal lesions with this abscess-like formation and with a hemorrhage in it. This is very typical of a tubercular choroidal granuloma. This is just to show some ocular investigations like what all we do in a patients of TB choroiditis. Like in this patient, you can see that some lesions are active. You can see all these fuzzy areas and some are inactive. These lesions are inactive, they are flat and some have fuzzy borders. And this is a very simple non-invasive investigation which is called autofluorescence, which shows active lesions as all the hyper autofluorescent because it depends upon the lipofuscin activity, and hypolesions and inactive lesions as hypolesions. So in such patients, you can altogether omit angiography to confirm the diagnosis or see the disease activity. Just to show how FFA looks in tubercular choroiditis or serpiginous choroiditis, early hypolesions followed by late leakage. And how OCT is helpful in such patients, especially in the granuloma patients. Here, if you are passing in OCT through a tubercular granuloma, you can see a huge choroidal bump with subretinal fluid, and this is typical called contact sign. And this is passing through the macula showing subretinal fluid. And when this patient has received ATT, you can see all these, they have healed, punched out lesions, and the OCT shows flattening of the lesion, rather RP atrophy here. Now, the another pattern of tubercular posterior uveitis is a patient can have occlusive vasculitis. You can see this, white exudative deposits along the vessels and hemorrhages. And very typical is if you have a perivascular choroiditis along with vasculitis, this is clinically very much suggestive that you are dealing with tubercular vasculitis. So if all these signs are present, you can investigate, you can get the Monto done, HRCT, which can show various old or active lesions. If equivocal Monto can go for TB quantiferon gold, and in doubt, you can go for a vitreous tab for PCR. A physician has to be consulted, and we can start with oral steroids if the disseminated or miliary TB is ruled out along with ATT. Now coming to syphilis, syphilis is a great mimicker. It has become uncommon now, again researching a sexually transmitted disease. And the uveitis is most common in the secondary stage of acquired syphilis. The commonest findings are this acute placoid posterior chorioretinopathy, which looks like faded over the posterior bole. And then there are superficial ground glass retinitis patches. You can see all these pictures. They are very typical of syphilis, but again, it can mimic like a tubercular choroiditis, like a toxoplasma. So syphilis has to be investigated in each and every case of uveitis. So every case of chorioretinitis, VDRL or TPH is must. And treatment is IV penicillin or oral ceftriaxones. Now coming on to fungal, the most common is ocular candidiasis. The risk factors are long-term IV infusion therapies, immunosuppressions, uncontrolled diabetes, and it can either present as these fluff snowballs in the center. So how they are different from the snowballs of sarcoidosis or intermediate uveitis? These snowballs are typical in the center or in the mid-vitreous because they are actually the candida balls, whereas the intermediate uveitis, the snowballs will be down in the inferior quadrant because they are in the they are inflammatory exudates and they are settled down with the gravity, or they can present as chorioretinitis lesions in the center. Diagnosis is again clinical as well as microbiological, and you can do labs, blood and urine cultures. Until unless the patient is sick, we normally don't get any fungal growth on the cultures. Normally we do a diagnostic vitrectomy, do a KOH fungal culture and vitreous PCRs, and treatment are systemic and intravitreal antifungals. Now coming on to non-infective posterior uveitis, the most common is sarcoidosis, and there are almost 7 signs which are described by the Association of Sarcoidosis, which are snowballs or string of pearls appearance, or you can have multiple chorioretinal or peripheral lesions, hypopigmented nummular regions, you can have periphlebitis with candlewax drippings, or you can have macroaneurysms with exudation, you can have optic disc granuloma, you can have, and the most important is usually they are bilateral, either they are clinically bilateral or the other eye may be involved subclinically, and which is confirmed on ocular imaging. The important labs which we do are the CT scan or chest X-ray, which shows typical this bilateral hilar lymphadenopathy, serum ACE levels, lysozymes, and the confirmation is done by tissue biopsy, usually from the chest. So a pulmonologist consultation is important. Now, this has already been covered in brief by the previous speaker. So if you see a hypopyon uveitis, which does not have fibrin, and if it is mobile, then it is must to have a fundus examination because you might be dealing with Behçet's disease, which is a multi-organ disease. And these are the various criteria for Behçet's disease. I hope these will be covered by the speakers in the pan-uveitis. So you have to have recurrent orogenital ulcers, eye lesions, and skin ulcers. And these are the various presentations of Behçet's disease. One can have just dense vitritis, can have multifocal retinitis. So it is the only cause of non-infective retinitis in the eye. You can have occlusive BRVOs in a young male or a female. And you can have, again, these occlusive peripheral BRVOs. So if you do an angiography in patients of Behçet's disease, so you will get a typical occlusive vasculitis. All the veins will be, or the arteries will be blocked, and there will be fern pattern in the late stage. This is very important viva question or exam question. This is very typical of Behçet's disease. So treatment part is again immunosuppressants and steroids. So just to summarize, depending upon the pattern, how you can pinpoint the etiology. If the pattern is a focal necrotizing retinitis adjacent to a scar with dense vitritis, suspect of toxoplasmosis. If you have rapidly progressive necrosis, tongue-shaped peripheral lesions, think of AN or PON. If you have an immunocompromised patient, hemorrhagic necrosis, think of CMV retinitis. If there is choroiditis, choroidal granuloma, or occlusive vasculitis with a endemic country like ours or history of TB exposure, rule out tuberculosis. If you have disc granulomas, periphlebitis with candle wax drippings, rule out sarcoid. If you have occlusive vasculitis or retinitis with hypopyon, rule out Behçet's disease. If you have large placoid chorioretinitis, granulous retinitis, one should think of syphilis. A systemic investigations in case of choroiditis, one should go for HRCT chest or X-ray chest. MON2, if equivocal, go for
Sharik, Sharik, slides are visible now?
Yes, sir.
Okay.
rickettsial. HLA visit is a clinical diagnosis and it is a very costly investigation. VGRL and TPHA. So, and the ancillary investigations are angiogram to differentiate between active or inactive lesions, to rule out secondary complications like look for NBE, non-perfusion areas, inflammatory CNVMs. OCT is normally to differentiate choroidal lesion for retinitis, look for microedema and further progression of the disease. And autofluorescence, as I have shown, to differentiate between active versus inactive lesions. Thank you.
Thank you so much, Dr. Pooja. It's an exhaustive topic, but you've covered it so well. And so
Yes.
PGs should know about these common posterior uveitis conditions like tuberculosis is important, syphilis is important as well, toxoplasmosis. And so very important points have been covered in this talk. Thank you so much.
Thank you, sir.
So we can go on to the next topic. Dr.
Yes,
Ankur.
yes, sir. Next topic is a very important topic in a way that residents do find it quite confusing how to differentiate one white dot syndrome from the another. So for them, it's mostly a list or differentiating point. So for the next talk, I would like to invite Dr. Tania to help us out with help the residents out with.
Ankur, Tanya is there. I can't see her.
Okay.
I think Dr. Anita is there only.
Yeah.
So let's get over with ma'am.
Yeah. Ma'am, very good evening. Ma'am is going to talk about PKH. PKH is another important disease that we see as a part of pan-uveitis. Over to you, ma'am.
Yeah, good evening. Hope my slides are visible.
Yes, yes, yes.
Am I audible, sir?
Yes, ma'am.
Yeah, okay. So truly honored to be a part of this lecture, and I'll be discussing about one of the most important topic, Koyanagi-Hara syndrome. And VKH syndrome is basically a multi-system autoimmune disorder which targets against the melanocyte-containing tissues, and which is triggered by preceding viral infection or any cutaneous injury which sensitizes the melanocyte antigen. So it is found to be associated with HLA-DR4 and most commonly seen in the pigmented races. So the clinical presentation is usually around second to fourth decade of life. However, pediatric VKH has also been reported, which is very resistant for the treatment. So the VKH usually goes into 4 stages. The first stage is a prodromal stage in which the patient presents with a prodromal like illness, flu-like illness, headache, neck rigidity. And on ocular examination, no signs were present except for choroidal folds. So the patient subsequently develop acute uveitic stage, where the patient will have a bilateral granulomatous panuveitis with secondary exudative or serous retinal detachment, along with the optic nerve inflammation. So the other thing called the Dallen-Fuchs nodule, which is nothing but a sub-RPE inflammatory deposits, usually consist of epithelioid cells and lymphocytes, is usually seen as a small yellowish white lesion in the inferior or infratemporal retina. It is more characteristically seen in the sympathetic ophthalmia, but can also be seen in the VKH. So when the patient is not treated properly at this stage, the patient can go for a convalescent stage, which is a stage of depigmentation. So where there is a diffuse choroidal pigment destruction, melanin destruction, and the patient will present with the sunset glow fungus. And the skin signs like vitiligo, poliosis, and alopecia can occur at this stage. So the next is a chronic recurrent stage, when the patient presents with a recurrent anterior granulomatous uveitis, and complications are more commonly seen at this stage. Posterior uveitis is almost rare in this stage. So coming to this case scenario, a 24-year-old male who had a sudden loss of vision 3 months back, associated with the prodromal symptoms without history of any systemic history or trauma or ocular history. So on examination, the patient had a bilateral granulomatous anterior uveitis with optic nerve inflammation and also exudative retinal detachment. So the patient was started on only local, at the local hospital, the patient was started only on topicals, and even with the late start of systemic steroids, the patient subsequently developed alopecia and then vitiligo poliosis. So this is a sunset glow fungus in which you can see this peripheral CRA patches, which represents the old Dallen-Fuchs nodule. So with this case, it is evident that early aggressive systemic suppression is important in treating the VKH patient. And for diagnosis, the most of the time, the diagnosis is clinical based on the revised diagnostic criteria. And based on these 5 points, the VKH is categorized as complete, incomplete, and probable, supported by the laboratory investigation. So laboratory investigation is to rule out other causes of panuveitis like tuberculosis, sarcoidosis, syphilis, and then supported by the ocular imaging. So the ocular imaging depends upon the stages. The first is a prodromal stage, in which the diagnostic test is CSF analysis, which shows pleocytosis in more than 80% of the cases. But even melanocyte macrophages can also be seen in the CSF analysis. And the only diagnostic test is ICG and UST scan, which shows the choroidal thickening. So next 3 stages, the diagnosis is imaging is usually multimodal. The first is EDA or sweat source OCT, in which there can be an increased choroidal thickness, RPE undulation, and SRF, which is mostly turbid, and bacillary layer detachment, subretinal hyperreflective dots, which represents the broken photoreceptors, and SRF around the disc, and this can be seen. So next is FFA, where we can see a pinpoint hyperfluorescent leak at the level of RPE, which can subsequently cause pooling at the late stage and the areas of serous detachment. So ICG, VKH is a choroidal disease, hence ICG is very useful in diagnosing. So early hyperfluorescent choroidal stromal vessels due to active choroiditis can be seen, and the areas of HDDs, hypocynosance dots, which is more evident in ICG when compared to the clinically and FFA. And in severe cases, these hyperfluorescence can also be seen. So UST B scan is helpful in case where there is in the peripheral, especially in the peripheral centers where the ICG and FFA is not available. In such cases, VKH can be diagnosed with a diffuse choroidal thickening, serous retinal detachment, vitritis can be seen, and especially it is used to differentiate it from the posterior scleritis, where we can see the T sign. So OCT angiography is a non-invasive technique in which the flow voids can be seen at the level of choriocapillaries and choroidal level, which correspond to the areas of ICG hyperreflective areas. Those HDD spots corresponds to the flow voids at the OCT angiography. Since it's a non-invasive technique, it can be used to monitor the response and to assess a complication like CNV. So at the later, these are the investigation at the active stages. At the later stage, convalescent stage, usually there will be a choroidal depigmentation, and that sunset low fundus correlate with the choroidal thinning on the EDA OCT. So as I said before, OCTA can be used to monitor the response to the treatment, and FFA usually shows the RPE window defects and block the fluorescence due to RPE migration. So in the chronic recurrent stage, this is a stage of a complication. So in FFA, we can see the CNVM, even in the ICG, CNVM can be appreciated. And any increase in the choroidal thickness at this stage, even in the presence of apparently good clinical control, is suggest underlying subclinical inflammation. So it is important to rule out the differential, because especially in case of CSCR, because steroid use can increase the can aggravate the CSR, but the treatment of VKH is a high dose oral steroid. So before starting the treatment, it is important to rule out the CSCR with the characteristic FFA findings, which was already discussed before. So the management, so the studies says that early aggressive immunosuppressive therapies like intravenous methylprednisolone and high dose oral steroids is beneficial to suppress the active, not only to suppress the active inflammation, but also prevent the disease recurrence and to avoid the sight-threatening complication. So early immunosuppressive therapies like azathioprine, mycophenolate, mofetil has also been found beneficial. To summarize, so any patient with bilateral granulomatous panuveitis with secondary exudative retinal detachment without the history of trauma or surgery or any other systemic history, it is important to suspect VKH. And VKH is not only a eye disease, it can involve the other melanocyte containing tissues like meninges, ear, skin, and hair. And imaging diagnosis is mainly clinical and supported by the laboratory and imaging techniques. Early aggressive treatment with the immunosuppressant therapy is crucial to prevent the chronic recurrence and also complication. It is important, since it's a chronic disease, it is important to follow up to know the risk of recurrences and to treat the complications. Thank you.
Thank you so much, Dr. Anitha. And first of all, sorry it went too late. I think Dr. Ankur, let's conclude here. I don't think there are any more speakers here. Thank you to all the speakers for your patience and the wonderful lecture. And we have a great attendance today. Thank you all students for logging in such a huge number. The registration was 1650 and at any point there were 500 students. So Dr. Ankur and Dr. Sisis, please conclude.
Yeah, thank you so much, Dr. Praful and Dr. Ankur. It was a wonderful session, and all talks were very good and very helpful for the PGs, I believe. And kudos to you for organizing this PG course, and which has been very successful. Thank you so much. Thank you to all the speakers. Dr. Ankur, you would like to say something? I think he's left, so we can close the session now, I think, Dr. Praful.
Yes, sir. I'm sorry, my baby is with me. She's
Yeah,
shouting a lot. So thank
please.
you, Ankur. You are the real star. You are sitting here since 6 p.m. and it's already 10 and you're still there. I could see.